generation of doctors here that would not lag behind their international colleagues with their professional skills and knowledge, and what's more, would be able to educate others coming after them. For this very purpose, he organized the training of around 100 Armenian physicians in the United States and gave the idea of continuing professional development.
Edgar շատ էր խոսում շարունակական բժշկական կրթության մասին.
Edgar talked a lot about continuing medical education, which we can say remained with us as a legacy from him. And when I was in the National Assembly and headed the Healthcare Committee, we set out to establish continuing professional development in Armenia by force of law.
Նախաձեռնությունը եւ այդ ծրագիրը եւ օրենքի ուժով մենք դա կարողացանք այսպես հաստատել Հայաստանում.
And then, as a gratitude to the great professor, a new neurology and neurosurgery service was founded in Arapgir Medical Center and was named after Professor Edgar Housepian. In the field of pediatric neurology, and in particular epilepsy, new opportunities were created for our leading specialists to develop other fields of neurology and neurosurgery, the main goal being the introduction of epilepsy surgery in our country. It is because 30% of 3,600 patients receiving epilepsy follow-up care are drug resistant, and half of them need to undergo a surgery. Until 2014, we cooperated with US, Canada, and some European countries. But from 2014 to 2016, we sent 6 patients to the University Hospital St. Ivan Rilsky in Sofia, Bulgaria, where we underwent successful surgeries. Inspired by those results, we decided to have the same treatment method in our country as well. Since 2016, 32 patients have already been operated, most of them successful. In the beginning, those surgeries were performed once a year with the presence of Bulgarian colleagues, but now our neurosurgeon performs most of the operations by himself in Armenia. The outcome of surgeries depend on proper pre-surgical examinations, which are possible to perform with high-standard equipment obtained thanks to our generous sponsors and partners. Starting from 2015, the team performs 24, 48, and 72-hour electroencephalographic video monitoring, which is an important test to diagnose epilepsy correctly. In 2021, for the first time in Armenia, specialists from Arapgir Medical Center performed the WADA test, the purpose of which is to determine the dominant brain hemisphere before the main epilepsy surgery in order not to damage the memory, speech, and motor areas of the brain. At the beginning of 2022, deep brain stimulation became a reality in Arapgir, which is used to treat movement disorders, including Parkinson's disease. It was performed for the first time in Armenia.
Զուգահեռ մենք ձեռք բերեցինք Edgar Housepian-ի
With the help of Edgar Housepian Foundation, we acquired a compound device called LexiFrame, through which we are going to introduce stereo EEG in near future, which is considered to be a high-level test in epilepsy surgery. Even today, with that device, we can perform surgeries on patients with movement disorders. By now, we have 2 successfully operated patients, a child and an adult, for whom this operation was the best solution because no drug could treat them. And just like this, step by step, the neurology and neurosurgery service of Arapgir Medical Center is expanding, with the multidisciplinary team making efforts for patients' health and life quality.
1988 թվականի երկրաշարժից հետո Հայաստանին օգնության ձեռք էին մեկնում ամբողջ աշխարհից։ Արհավիրքը շուրջ 25,000 մարդու կյանք էր խլել, 100 հազարավորներին թողել անտուն ու անապրուստ։ Այդ օրերին Հայաստան հասավ նաև Միացյալ Նահանգներում ապրող մեր հայրենակիցների Թորգոմ arczepiskopos Մանուկյանի, Գևորգ Հովնանյանի եւ դոկտոր Էդգար Հուսեփյանի համատեղ ջանքերով ուղարկված օգնությունը, որ հետագայում հիշվելու էր որպես Հայ օգնության ֆոնդի ՀՕՖ-ի առաջին հումանիտար աջակցությունը Հայաստանին։ Այդ ժամանակվանից ի վեր Հայ օգնության ֆոնդը Հայաստանում եւ Արցախում իրականացրել է 300-ից ավել մարդասիրական ծրագրեր եւ բժշկական ծրագրերը 25 տարի շարունակ ղեկավարել է Կոլումբիայի Երիցական բժշկական կենտրոնի կլինիկական նյարդաբանական վիրաբուժության ամբիոնի պրոֆեսոր Էդգար Հոսեփյանը, զուգահեռաբար լինելով նաեւ ՀՕՖ-ի փոխնախագահը։ Այդ տարիներին դոկտոր Հուսեփյանը ծանոթացել եւ ընկերացել է նորանկախ մեր պետության առողջապահության առաջին նախարար պրոֆեսոր Արա Բաբլոյանի հետ, նախաձեռնելով մի շարք նորարարություններ ուղղված առողջապահության զարգացմանը մեր երկրում։
Գիտեք, երբեք դուք չեք կարող որևէ մի անգամ նկատեք, որ Էդգար Հոսեփյանը ձայնը կարող է բարձրացնել։ Նա միշտ խոսում էր այսպես շատ հանդարտ ձայնով, հանդարտ ոճով, այսպես, բայց բավականի հստակ եւ բավականի այսպես իմպերատիվ։ Այսինքն այդ իմպերատիվությունը գալիս է նորից եմ ասում, ոչ թե նա ինչ-որ ինտոնացիա էր ընտրում, ինչ-որ խիստ բառեր էր ասում կամ ձայն էր բարձրացնում, այլ գալիս էր նրանից, որ ինքը հիմնավորում էր անհրաժեշտությունը եւ շարունակական հետևում էր, որ այդ անհրաժեշտությունը ներմուծվի կյանք, որ դա իրականացվի եւ դա շատ բնորոշ էր Էդգարին։
Հայրենիքին օգնությունը Էդգար Հուսեփյանի համոզմամբ չպիտի լիներ միայն նյութական։ Նա ցանկանում էր այստեղ տեսնել բժիշկների այնպիսի սերունդ, որ մասնագիտական իր գիտելիքներով եւ հմտություններով հետ չէր մնա համաշխարհային առաջատարներից եւ ավելին կկարողանար կրթել նաեւ իրենից հետո եկողներին։ Հենց այդ նպատակով նա կազմակերպեց շուրջ 100 հայաստանցի բժիշկների վերապատրաստումը Միացյալ Նահանգներում եւ տվեց շարունակական մասնագիտական զարգացման միտքը։
Էդգարը շատ էր խոսում շարունակական բժշկական կրթության մասին, որը կարելի ասել, որ այսպես մնաց մեզ մոտ որպես ժառանգություն իրենից, եւ երբ որ ես արդեն ազգային ժողովում էի եւ ղեկավարում էի առողջապահության հանձնաժողովը, ապա ձեռնամուխ եղանք, որպեսզի օրենքի ուժով դա մտցնենք եւ դա կոչվեց արդեն շարունակական մասնագիտական զարգացման այդ նախաձեռնությունը եւ այդ ծրագիրը եւ օրենքի ուժով մենք դա կարողացանք այսպես հաստատել Հայաստանում։
Եվ ահա որպես երախտիկ մեծանուն պրոֆեսորին Արաբկիր բժշկական համալիրում հիմնվում է նոր նյարդաբանության եւ նյարդավիրաբուժության ծառայություն, կրելով Էդգար Հուսեփյանի պատվավոր անունը։ Մանկական նյարդաբանության, մասնավորապես էպիլեպտոլոգիայի ոլորտում հանրապետության առաջատար մեր մասնագետների համար ստեղծվեցին նոր հնարավորություններ զարգացնելու նյարդաբանության եւ նյարդավիրաբուժության այլ ճյուղեր եւս, իհարկե որպես գերնպատակ ունենալով էպիլեպսիայի ժամանակ վիրահատական միջամտության ներդրումը մեր երկրում, որովհետեւ մանկական էպիլեպտոլոգիական դիսպանսերում գրանցված 3600 պացիենտների 30%-ի մոտ հիվանդությունը դեղորայքակայուն է եւ նրանց կեսը ենթակա է վիրահատության։
Մինչև 2014 թվականը մենք համագործակցում ենք տարբեր երկրների հետ, Ամերիկայի, Կանադայի, եվրոպական տարբեր երկրների հետ, բայց հենց 2014-ին մենք 14-ից մինչ 16 թվականները մենք թվով 6 պացիենտ ուղարկեցինք Բուլղարիա, Սոֆիա, համալսարանական Սուրբ Իվան Ռիլսկու հիվանդանոց եւ այնտեղ նրանք բարեհաջող վիրահատվեցին եւ ոգեշնչված այդ արդյունքներից մենք որոշեցինք այդ նույն բուժման մեթոդը ունենալ նաեւ մեր երկրում 2016-ից մինչ այսօր մենք արդեն ունենք թվով 32 վիրահատած հիվանդ բարեհաջող մեծ տոկոս բարեհաջող թվով եւ սկզբում այդ վիրահատությունները կատարվում էին տարեկան 1 անգամ միայն բուլղարացի գործընկերների ներկայությամբ, իսկ վերջին տարիներին արդեն մեր նյարդավիրաբույժը ինքնուրույն կարողանում է այդ վիրահատությունների մեծ մասը կատարել Հայաստանում։
Արդյունավետ վիրահատությունների հիմնական երաշխիքը որակյալ հետազոտություններն են, որոնք հնարավոր են դարձել լավագույն սարքավորումների միջոցով ձեռք բերված հավատարիմ գործընկերների օգնությամբ։ 2015 թվականից թիմը սկսեց իրականացնել 24, 48 եւ 72 ժամյա էլեկտրաենցեֆալոգրաֆիկ վիդեոմոնիտորինգ կարևորագույն հետազոտություն էպիլեպսիայի ճշգրիտ ախտորոշման համար։ 2021 թվականին առաջին անգամ Հայաստանում արաբկիրցիները կատարեցին WADA թեստ, որի նպատակն է նախքան էպիլեպսիայի բուն վիրահատությունը որոշել դոմինանտ կիսագունդը վիրահատության ժամանակ խոսքի, հիշողության շարժողական կենտրոնները չվնասելու համար։ 2022 թվականի սկզբին արաբկիրում իրականություն դարձավ գլխուղեղի խորանիստ ստիմուլյացիան շարժողական հիվանդությունների, այդ թվում պարկինսոնիզմի ժամանակ, կրկին առաջին անգամ Հայաստանում։
Զուգահեռ մենք ձեռք բերեցինք Edgar Housepian-ի ֆոնդի օգնությամբ մի բարդ սարք, որը կոչվում է Lexel Frame, որի միջոցով մենք պատրաստում ենք մոտ ապագայում նաև ներդնել ստերեո EEG, որը հանդիսանում է էպիլեպսիայի վիրաբուժության ամենաբարձր մակարդակի հետազոտություն։ Բայց արդեն նույնիսկ այսօր այդ ֆրեյմի օգնությամբ մենք կարողանում ենք վիրահատել շարժողական խնդիրներ ունեցող հիվանդներին, այսօր միայն 2 հիվանդ, երեխա եւ մեծահասակ, բայց շատ բարեհաջող այդ կուզենայի շեշտել, որովհետեւ որևէ դեղորայքային բուժում այդ հիվանդներին չէր կարող առողջացնել, իսկ այդ վիրահատությունը պացիենտների համար կրկին փրկություն էր։
Այսպես քայլ-քայլ առաջ գնալով էլ ընդլայնվում է արաբկիր բժշկական համալիրի Էդգար Հուսեփյանի անվան նյարդաբանության եւ նյարդավիրաբուժության ծառայությունը, բազմամասնագիտական իր թիմով չխնայելով ջանքերը հանուն պացիենտների առողջության եւ կյանքի որակի։
After the 1988 earthquake, people from all over the world reached out to help Armenia. The disaster took away 25,000 lives, leaving hundreds of thousands homeless and destitute. In those days, aid relief from our compatriots living in the US, Archbishop Torgom Manukyan, Gevorg Hovnanyan, and Dr. Edgar Housepian reached Armenia. The aid would later be remembered as the first humanitarian aid to Armenia by the Fund for Armenian Relief. Since then, the Fund for Armenian Relief has implemented more than 300 humanitarian projects in Armenia and Artsakh. For 25 years, medical programs were headed by Edgar Housepian, clinical neurosurgery professor in Columbia University Medical School, vice president of the Fund for Armenian Relief. During those years, Dr. Housepian met and became friends with the First Minister of Health of our newly independent republic, Professor Arab Abloyan. Together, they initiated a number of innovations aimed at the development of healthcare in our country. Edgar Housepian would never raise his voice. He always spoke softly but clearly, confidently and imperatively. The imperativeness came from the fact that he justified the necessity and continuously followed that the necessity was brought into life and was implemented. It was very typical of Edgar. According to Edgar Housepian, the help to the motherland should not be only material. He wanted to see such a generation of doctors here that would not lag behind their international colleagues with their professional skills and knowledge, and what's more, would be able to educate others coming after them. For this very purpose, he organized the training of around 100 Armenian physicians in the United States and gave the idea of continuing professional development.
Edgar շատ էր խոսում շարունակական բժշկական կրթության մասին.
Edgar talked a lot about continuing medical education, which we can say remained with us as a legacy from him. And when I was in the National Assembly and headed the Healthcare Committee, we set out to establish continuing professional development in Armenia by force of law.
Այդ նախաձեռնությունը եւ այդ ծրագիրը եւ օրենքի ուժով մենք դա կարողացանք այսպես հաստատել Հայաստանում.
And then, as a gratitude to the great professor, a new neurology and neurosurgery service was founded in Arapgir Medical Center and was named after Professor Edgar Housepian. In the field of pediatric neurology, and in particular epileptology, new opportunities were created for our leading specialists to develop other fields of neurology and neurosurgery, the main goal being the introduction of the epilepsy surgery in our country. It is because 30% of 3,600 patients registered in epilepsy follow-up care are drug resistant and half of them need to undergo a surgery.
Մինչև 2014 թվականը մենք համագործակցում ենք տարբեր
Until 2014, we cooperated with US, Canada, and some European countries. But from 2014 to 2016, we sent 6 patients to the University Hospital St. Ivan Rilsky in Sofia, Bulgaria, where we underwent successful surgeries. Inspired by those results, we decided to have the same treatment method in our country as well. Since 2016, 32 patients have already been operated, most of them successful. In the beginning, those surgeries were performed once a year with the presence of Bulgarian colleagues, but now our neurosurgeon performs most of the operations by himself in Armenia.
Կարողանում է այդ վիրահատությունների մեծ մասը կատարել Հայաստանում։
The outcome of surgeries depend on proper pre-surgical examinations, which are possible to perform with high-standard equipment obtained thanks to our generous sponsors and partners. Starting from 2015, the team performs 24, 48, and 72-hour electroencephalographic video monitoring, which is an important test to diagnose epilepsy correctly. In 2021, for the first time in Armenia, specialists from Arapgir Medical Center performed the WADA test, the purpose of which is to determine the dominant brain hemisphere before the main epilepsy surgery in order not to damage the memory, speech, and motor areas of the brain. At the beginning of 2022, deep brain stimulation became a reality in Arapgir, which is used to treat movement disorders, including Parkinson's disease. It was performed for the first time in Armenia.
Զուգահեռ մենք ձեռք բերեցինք Edgar Housepian-ի
With the help of Edgar Housepian Foundation, we acquired a compound device called LexiFrame, through which we are going to introduce stereo EEG in near future, which is considered to be a high-level test in epilepsy surgery. Even today, with that device, we can perform surgeries on patients with movement disorders. By now, we have 2 successfully operated patients, a child and an adult, for whom this operation was the best solution because no drug could treat them. And just like this, step by step, the neurology and neurosurgery service of Arapgir Medical Center is expanding, with the multidisciplinary team making efforts for patients' health and life quality.
Հարգելի գործընկերներ, հիշեցնեմ, որ թարգմանություն կա եւ սիմպոզիումը լինելու է անգլերեն լեզվով, այն մասնակիցները, ովքեր ցանկանում են լսել հայերեն, պետք է ընտրեն հայերեն լեզվի կոճակը, որպեսզի կարողանան լսել։ Խնդրում եմ ձեր էկրանի ներքևում չաթում կտեսնեք ինչպես պետք է իրականացնեք քայլերը, որպեսզի կարողանաք միանալ եւ լսել հայերեն։ Կարող եք սեղմել interpretation կամ перевод կոճակի վրա, որը ձեր էկրանի ներքևի հատվածում է եւ ընտրեք լեզուն։ Շնորհակալություն։
Նորից կնշանակեք։ Խնդրում եմ նորից նշանակել թարգմանիչ։
Good afternoon, everyone. I am honored to welcome you all today on behalf of organizers of this meeting. My name is Biaina Sukhudyan, and I am the chair of the first clinical neuroscience symposium on epilepsy dedicated to the memory of Professor Edgar Housepian. Just before opening this symposium, you had the possibility to watch a short film about him. For those who missed it, the film in Armenian and in English will be repeated during breaks. For those who didn't know Professor Housepian, I would advise to listen to the speech of the Executive Director of Fund for Armenian Relief, Mr. Garnik Nanagulian, in several minutes. I am excited to see more than 500 participants from different countries, and surely we have an amazing faculty, including lecturers from Armenia, Europe, and USA. In this 2 days virtual conference, we will touch the diagnostics and surgical treatment of drug-resistant epilepsies in children and in adults. The message of this conference is to give the updated information in this field. The program is shaped in a way to attract your interest, so I trust that we will be successful. We plan to have annual meetings and in future, and I hope to see you all in person next year. I want to thank the International Center of Professional Development for technical support and for providing a possibility to use this platform. Thank you for joining us, and perhaps we can make a start.
Շնորհակալություն դոկտոր Սուխուդյան, հարգելի գործընկերներ, բարի երեկո, գործընկերներ Միացյալ Նահանգներից, երևի թե բարի լույս, բարի օր, ուրախ եմ ողջունել ձեզ պրոֆեսոր Էդգար Հousepian-ի անվան կլինիկական նյարդաբանության առաջի սիմպոզիումի շրջանակներում, եւ այժմ ես ցանկանում եմ խոսքը փոխանցել Գառնիկ Նանագուլյանին. Պարոն Նանագուլյանը հանդիսանում է Ամերիկայի Միացյալ Նահանգների Հայօգնության ֆոնդի գործադիր տնօրենը, նա կխոսի պրոֆեսոր Էդգար Հousepian-ի մասին, ով միջազգային ճանաչում ունեցող նյարդավիրաբույժ էր։ Խնդրեմ պարոն Նանագուլյան։
Hello. My name is Garnik Nanagulian, and I am the Executive Director of the Fund for Armenian Relief. I want to thank you, the people at the ICPD, for organizing this symposium and honoring the great Armenian Dr. Edgar Housepian. As well, I was asked to share my thoughts about Dr. H. I was wondering how I could fit in the limited time frame of this presentation to be able to convey what Dr. Housepian means to the well-being of the Armenian people. He's one of those giants whose legacy is hard to fit in any limited framework or presentation. We all, including, of course, the Fund for Armenian Relief, were blessed to have enjoyed his razor-sharp counsel, his visionary leadership, and his gentle, down-to-earth presence for so many years. I wish he could have been with us today, as I, for one, I miss him very, very much. He was, of course, an internationally renowned neurosurgeon at Columbia Presbyterian Hospital. For those who knew about his background, it was obvious that Dr. Housepian carried the best he represented from his genes. He was hired to a remarkable family tradition of compassionate involvement in Armenian life. In an earlier era, his parents were pioneers in humane outreach to our homeland. Their example inspired their son to excel in his profession and to share his gifts with those who were less fortunate. Like his parents, Edgar Housepian could not sit by when his countrymen were in dire need. For him, the motivating crisis was the 1988 earthquake in Armenia. In what is now an almost iconic story of daring determination, Dr. Housepian, with other FAR leaders, embarked on a mission of mercy to our homeland mere days after the disastrous earthquake, to assess the damage and formulate a response to it. But Dr. Housepian's work didn't stop after the immediate crisis subsided. It only accelerated. For more than 25 years, he was the guiding light in the effort to restructure the healthcare system of the Republic of Armenia. Thanks to his foresight, a new generation of Armenian physicians would enjoy opportunities for training and education which were impossible to even imagine previously. But above all, Dr. Housepian's efforts made lasting improvements in the way people are cared for in Armenia today. According to some of his colleagues, Dr. Housepian's legacy is in the creation of the foundation of sustainable healthcare in Armenia through his famous Fellows program and for his mentorship that followed after that. I think it is only natural that the name of Dr. Housepian is on the walls of the Arapkir Medical Clinic, because Dr. Babloyan was the most reliable partner for Dr. Housepian and his plans. And today's symposium is nothing but another celebration of Dr. Housepian's legacy, with a promise to expand the capacities of Dr. Edgar Housepian Center to reach out to more people with more complex neurological problems with highly professional treatment. When he passed away in a cold day of 2014, November, Dr. Housepian was mourned as a towering figure of the worldwide Armenian community. With sadness, but yet also with gratitude, we remember his life today as an example of the Armenian heritage at its best. Thank you for honoring the name and work of one of the best Armenians of all times. I wish you productive work and the beginning or continuation of mutually rewarding collaboration. Thank you.
Շնորհակալություն, պարոն Նանագուլյան, շնորհակալություն, իսկապես դոկտոր Հousepiani մասին կարելի է շատ երկար խոսել, ժամերով, օրերով, եւ մտովին գնալով 90-ականներին եւ 80-ականների վերջերին, երկրաշարժից փլուզված երկիր, հետագայում պատերազմ, բայց մեր առջև լուրջ խնդիրներ, երկրի զարգացում, առողջապահության, մարդկանց առողջության պահպանում եւ այս ամենին իհարկե մեզ ամենամեծ այսպես օժանդակությունը տվեց պրոֆեսոր Էդգար Հousepiանը։ Շնորհակալություն, պարոն Նանագուլյան։ Արգելի գործընկերներ, ես ուղղակի ցանկանում եմ ձեզ տեղեկացնել, որ սիմպոզիումի ժամանակ դուք ձեզ մոտ հավանական կառաջանան հարցեր, մասնագիտական հարցեր, դուք կարող եք ձեր հարցերը գրավոր ներկայացնել զրուցարանում, չաթում, բանախոսները կփորձեն հարց ու պատասխանի ժամին պատասխանել ձեր հարցերին, եթե ժամանակի սահմանափակման պատճառով չհասցնեն պատասխանել բոլոր ձեր հարցերին, ապա մենք հետագայում կուղարկենք ձեզ այդ հարցերի պատասխանները։ Այժմ ես ցանկանում եմ ներկայացնել իմ գործընկերոջը, մոդերատոր դոկտոր Ռաֆի Ավետիսյանին։ Դոկտոր Ռաֆի Ավետիսյանը Ամերիկայի Միացյալ Նահանգների Cleveland կլինիկայի Ինչքան ժամանակ չեք լսել ինձ։
Շատ կարճ ասենք։
Այժմ ես ցանկանում եմ ներկայացնել իմ գործընկերոջը, մոդերատոր դոկտոր Ռաֆի Ավետիսյանին։ Դոկտոր Ռաֆի Ավետիսյանը ԱՄՆ-ի Cleveland կլինիկայի անեսթեզիոլոգիայի պրոֆեսոր է, Cleveland կլինիկայի բժշկական անձնակազմի ներկայիս ընտրված նախագահն է եւ նյարդավիրաբուժական անեսթեզիոլոգիայի կրթաթոշակային ծրագրերի տնօրենը։ Նա ԱՄՆ-ում նյարդաանեսթեզիոլոգիայի կրթական ծրագրերի հիմնադիրներից մեկն է, ինչպես նաև պերիօպերատիվ նյարդաբանության կրթության միջազգային խորհրդի գործադիր կոմիտեի անդամ։ Դոկտոր Ռաֆի Ավետիսյանը Հայաստանում մասնագիտական զարգացման միջազգային կենտրոնի ICPD-ի հիմնադիր նախագահն է։ Կենտրոնի նպատակն է Հայաստանի եւ Արցախի առողջապահության ոլորտի մասնագետներին տրամադրել գիտելիքներ մասնագիտական փորձի շարունակական բարելավման համար։ Այս սիմպոզիումը այդ միջոցառումներից մեկն է։ Մինչ որ ես խոսքը կփոխանցեմ Ռաֆի Ավետիսյանին, ես կցանկանայի եւս մեկ անգամ հիշեցնել, որ մեր սիմպոզիումը երկու լեզվով է եւ եթե նրանք ովքեր ունեն դժվարություններ կարող են չաթում հարցեր տալ, ինչպես կարող են լեզուն միացնել իրենց ցանկալի լեզուն եւ նույն ժամանակ հարց ու պատասխանները կարող են ներկայացնել չաթում։ Այժմ ուրախ եմ խոսքը փոխանցել դոկտոր Ավետիսյանին ներկայացնելու մեր սիմպոզիումի առաջի բանախոսին։ Խնդրեմ դոկտոր Ավետիսյան։
Շատ շնորհակալություն, դոկտոր Բաբլոյան, եթե կարելի է ես անգլերենով ֆրանսիացիով խոսեմ, որ մեր անգլիախոսներն կարողանան հասկանալ։ Thank you very much, Dr. Pavloyan, for introducing me. On behalf of International Center for Professional Development, I would like to welcome everyone to this conference. In particular, I want to thank all our partners, specifically our sustainer sponsors, including Fund for Armenian Relief, FAR, Armenian American Medical Association of Boston, National Institute of Health. I'd like to also thank the chair, my good friend, Dr. Biayna Sukudyan, and my good friends, co-chairs, Dr. Sebat Batalyan, Samson Khachaturian, and Petya Dimova. I'd like to thank all the speakers that have participated. I would like to thank the interpreters and all my colleagues in International Center for Professional Development, without whose work this would not have been possible. So coming back, we're going to start our first session, and I would like to introduce the first speaker, Dr. Petya Dimova. Dr. Dimova is an associate professor of neurology. She received her education and training at Medical University of Sofia and specialized in neurology and pediatric neurology. Her work, mostly in epilepsy and EEG, has been conducted in clinical child neurology of Sitnau University Hospital. She's had additional experience and specialization in Freiburg in Germany, Vienna, Grenoble, multiple SEEG courses, many of which she has been a lecturer and tutor. She started in the Bulgarian epilepsy surgery program, now leading the monitoring and epileptology unit and the president of the Bulgarian chapter of LAE. We're ready to hear your lecture, Dr. Timur.
Thank you for introduction. Hello, everybody. First, I would like to thank the organizers to have invited me to this Neuroscience Symposium, to be part of it, because it's dedicated to epilepsy, and also to say that I'm very happy to be part also of the development of Armenian epilepsy surgery program, a big part of which are also children with resistant epilepsy, and I hope we could help a lot of patients and our colleagues, dear colleagues in Armenia. I don't have anything to disclose it as conflict of interest, but just to mention that my interest is in some of the older seizure classification, despite we are using more and more the new one, and we can compare the citation, but still I like very much what has been done by Hans Luders and many other colleagues, because not only because many of them are my teachers and mentors, but also because it is very important to really have a good classification system of the seizures, and especially in the childhood age. So in some part of my talk, I will also use some of these terms created and included in this classification system by Hans Luders and some of the founders of the contemporary epilepsy surgery. What about children and childhood? We know that there are at least 4 stages according to developmental psychology. All these 4 stages, they show the fastest developing of the human being, not only, but especially of its brain. So we can suppose, and many of us know, that childhood seizures are also developing, so they are changing during all these 4 stages of the childhood development. This is one of the main papers I found about semiology of epileptic seizures in childhood. This is about the first year of life. This paper and study appeared at the end of previous century. Is done by the Cleveland Clinic, and they found that a significant amount of the seizure types in childhood are presented by epileptic spasms. Clonic and hypomotor seizures are on the 2nd place, and tonic seizures are on the 4th place. So these are the predominant motor features we found in epilepsy seizures in childhood. So they account for more than 80% of all seizure types. So conclusion of the authors was that repertoire of the seizures in this age period in infancy and childhood is quite limited. So also that epileptic spasms may be focal as well as generalized, and video EEG monitoring and neuroimaging, so especially modern neuroimaging and MRI is crucial for clarifying the nature of the seizures. This was found also by another study published 2006 by 2 other experts, Doug Nordley and Christian Korf. So they described 30 seizure type in close to 70 patients in the age range of 1 to 23 months. And they also found that majority of the seizures were presented by spasm, focal clonic and focal tonic seizures, and also what they called behavior arrest with version. So more than 2/3 of the children presented these seizure types. Again, they emphasize that video EEG and accurate seizure classification extremely important, because they give us this fundamental information which is helpful to establish the correct epilepsy syndrome diagnosis, but also to find the correct treatment option, including epilepsy surgery. The rarest type in this study is generalized tonic-clonic, this pure behavior arrest without focal sign of version, but also hypermotor seizure, which was quite unusual. So these are the rarest seizure types. And they also found that this classic generalized tonic-clonic seizure was not observed. The generalized seizure appeared quite later in comparison to focal seizures, and spasms were included because they were probably the most common seizure type with the median age of 8 to 8.5 months, and even they can be the predominant one in this age, especially if they are combined with focal seizures. So very early they found that the so-called diffuse tonic to focal clonic seizure can appear from birth to the age of 14 months, and also focal clonic seizures and this particular type of behavioral arrest with version. A bit later, they found that generalized tonic and clonic seizure can appear still at the age up to 1 year. Also interesting that found that infantile seizures are short, both in clinical and electroencephalographic term, from close to half a minute to less than 1 minute in terms of EEG, and also that we cannot rely solely on the clinical observation to predict what be the electrographic correlate of a seizure. So video EEG extremely useful and even necessary to be performed in order to clarify the nature and localization of the seizures. And this is one of the main studies done by Andras Fogarash and the team in one of the oldest epilepsy surgery center in Europe, in Bielefeld in 2001, so more than 20 years ago. They focused on the main seizure epilepsies in childhood, and first then they evaluated the frontal lobe epilepsy. They also confirmed that epileptic spasm and these subtle behavioral changes are very frequent, in contrast to hypermotor seizures and these complex motor automatic behaviors which are not seen. And also generalized tonic-clonic seizures were quite unusual. So frontal lobe epilepsy bears very prominent age-related features in children less than 7 years. This is the last study I found published this year in Annals Chart Neurology. Of course, they found different focal seizures in frontal lobe epilepsy, the focal tonic being the most frequent, followed by hypermotor and focal clonic, but also a lot of patients, so 21 out of 56 patients in the age of 1 month to 14 years, they reported some aura. Interestingly, that focal tonic, not unexpected, they were related to a premotor epileptic zone on the scalp EEG. Prefrontal epileptic zone were found to correspond mostly to hypermotor seizures, which were also related to premotor one, but also, as you see, focal clonic seizures, which we usually correlate to a central epileptic zone or premotor one or mesial frontal, they actually much more often correspond to a generalized EEG, which is also true for the other seizure types like the focal tonic. So EEG and seizure semiology in this group, even in the bigger one from 1 to 14 years, it's not easy to correlate based only on the seizure semiology. As to the aura, it was found in 21 seizures, and interestingly, it was not only somatosensory which was present in 9 of the children, but also could be psychic of nature, which we usually relate to a temporal lobe epileptic zone. So if present, aura is very important, but actually it could be evaluated in order to understand the characteristic of frontal lobe seizures, because also many of the children, they do have negative MRI, it is close to 70%, and EEG, even in focal seizures, could be normal indirectly, like here in the study in close to 1/4 of the seizures. The team of Bertel Bielefeld and Andras especially evaluated also the other types of extratemporal epilepsy, and found, not surprisingly, that tonic seizure and clonic seizures were more frequent in frontal lobe epilepsy, in contrast to posterior cortical epilepsy, when they found this well-known sign of postictal nose wiping, which was not true for myoclonic components, for spasms as peculiar seizure types in childhood, for so-called psychomotor seizure, atonic seizure, and different types of automatism. as well as for vocalization and eye deviation, because they could be observed in posterior cortex, but also in frontal lobe epilepsy. Of course, it's very useful to know the appearance of the seizures and also the type of the aura, because, of course, visual aura is very specific. It's characteristic for posterior cortex epilepsy, and nocturnal appearance is more often and usual found also in children in frontal lobe epilepsy. Posterior cortex epilepsy are quite frequent in children as well, but in younger children, this group also evaluated the seizures and found they are much more frequent than in adults, but usually of shorter duration. The children, of course, much rarely report aura, and this is, of course, important to ask in verbal children, but if not present, the ictal signs, very subtle, like smile, flush, a small head nod, and some behavioral changes can be very frequent and also typical for the posterior cortex seizures in children. This is another study on posterior cortex epilepsy done by the group of Claudio Munari Center and with main author Alexandra Liava, but Stefano Francioni is one of the experts of posterior cortex epilepsy, also in children. Majority of these children they studied presented with complex partial seizure or such with focal unaware seizures according to the recent classification. In more than quarter of this group, they found also that spasm predominated, and usually the onset was quite early, even before 1 year of age. As you see, secondary generalized seizures were not so often seen, and as found also by Bielefeld group, the frequency of the seizures were quite high, so majority of them presented daily seizures, and multiple, and even 7 out of the 62 cases presented with status epilepticus. As to the prevalent ictal semiology in pediatric age group, of course, to mention again that subjective visual symptoms are very important, but if they cannot be reported by children, we have to seek for oculomotor signs, which are important, and the eye deviation especially, which could be contralateral in majority of cases, regardless tonic or clonic, but even monoocular. In some of the cases, like 9 of the tonic deviation cases, it could be also ipsilateral. The evolution is various. Sometimes it follows the frontal lobe pattern, so-called with axial deviation of the head, and then with hemiclonic or adversive seizures. And this was found in 1/3 of the cases, usually in children which have who have a pure parietal lobe localization of the focus, whereas temporal lobe pattern with autonomic vegetative sign and some automatism, usually oroalimentary, they are much more often seen in pure occipital lobe localization. So this is the ventral stem, and the other one is the parieto-frontal stream of the spreading of the seizures. The visual aura is the most frequent, of course, was present, however, in 22 out of these 56 cases. And interestingly, in a lot of the cases, they found that fear is quite prominent side, so close to 20% of the cases they presented fear, which is also to say not only a temporal sign in these patients, because the temporal hour was regarded as abdominal or psychic, similar to adults. Another study done by a group in Cleveland found that as in adults, auras and automatism prevailed in temporal lobe seizures, but hypomotor, as already mentioned, is quite typical semiology for frontal lobe seizures, and usually hypermotor semiology is more characteristic for multilobar or temporal lobe seizures. And the other seizure types like tonic, clonic, or combined tonic-clonic seizures, as well as tonic, myoclonic, and spas, they have usually or exclusively generalized EEG and were generalized in their nature. Automatism in temporal lobe similar to adults, where manual and oral and the proximal automatism are much more often in frontal lobe epilepsy. However, as you see, hyperkinetic, which is hypermotor seizures, usually were primary multilobar, but could be even also frequently found in frontal lobe epilepsy or temporal lobe epilepsy. And in these patients, they were a bit more common, often seen in temporal lobe epilepsy, so 25 in comparison to 22 children. And coming to the most common epilepsy in adult, which is also important in children, this is temporal lobe seizures. Again, Betel, Tim, and Andras evaluated this type of epilepsy and found that the motor features were very marked and quite early, quite prominent in children, and they consisted of tonic and myoclonic components, as well as already mentioned, of epileptic spasms. Of course, which is interesting and also confirmed, but other authors earlier and later, the frequency of these motor components decrease with age. So the conclusions of this study is that probably events in brain maturation significantly affect the semiology of the seizures, so they may override the more typical localizing features we know quite well from adult type temporal lobe epilepsy. And these are two cases which confirm this age-specific etiology, because it is smaller child, the younger one, Valerie, with a Leah on the right temporal. The semiology is quite different from the older child who is already almost 2 years old, with the same etiology on the same side. So in this child, the spasm prevailed and quite symmetric. And in the other child, we can see tonic posturing, the orientation to the left, and the immobilization of the left extremities. So seizure semiology is age-specific, and spasms are really occurring in younger children. About the evolution of this seizure semiology, is a very nice overview by Prakash Kotagal and colleague. So again, they confirm that infants and small children up to 3 years, they have a very prominent motor manifestation like tonic, myoclonic. They can be bilateral, symmetric, as we saw. And in older children, especially in school age, these motor phenomena are more prominent, and they they change to this contralateral dystonic posturing, which is already quite common. And ours is quite rare or difficult to recognize in small children. It's common, and especially the abdominal type, which is temporal lobe specific, which is seen mostly in older children. As to automatism, they are quite common in all ages, but still they become more complex with age, and hand automatisms add to oral elementary, which can be present also in infants and babies. So this is another nice study done, published last year and done by the group in Rothschild in France. So they studied semiology of temporal lobe seizures in preschool children in close to 30 patients. Many of them are explored by invasive electrodes, temporal depth electrodes, but also foramen oval and sphenoidal electrodes. And they found that majority of the children who have specific ictal semiology similar to adults, they belong to this group of mesiotemporal lobe epilepsy, a bit more than half of these children. And it was not true for the other localization of temporal lobe epilepsy like polar or mesiolateral or clear lateral, especially for the lateral epilepsy. None of the children reporting the classic including auditory hours, of which we know from adults. Quite a lot of these children had also infantile spasm, more than 10%, and in 1/3 of them, close to 1/3, they have clear lateralization stunt. So the conclusion is that again, seizures were non-specific. Quite often they have been like subtle events or infantile spasm, but interestingly, many of the seizures which were due by Liat in mesiotemporal lobe epilepsy were characterized by apnea, so this is quite specific for this type of epilepsy. And because I mentioned many times, and it was out in this study, this epileptic spasm are very typical for children in all ages, but especially in younger one, in babies, and the early onset epilepsy. This is a study done again by Dr. Nordley and Burke and a Korean colleague. They evaluated 3 groups of EEG findings correlating to spasm, hypsarrhythmia, and no hypsarrhythmia, so normal background, and 2 age group less than 1 year and above the age of 1 year. So there were no differences in underlying causes in their location or extent of the MRI lesion, if present, but also the ictal patterns of the spasm are remarkably similar. So they concluded that the spasms present, epileptic spasm present an age-dependent epileptic manifestation, and actually they do not present different syndromes. And this is also can be confirmed by these 2 cases. In the first case, this is a genetic syndrome, severe one, and this is actually a unilateral encephaloplastic lesion. So of course there are semiologic differences, neurological differences, because in this child there were no prominent. There is asymmetry because of the chemical release on the right, but still this is spasm prevailing, so they can be seen in focal as well as in generalized epilepsy and in various etiology of the disorder. So there are subtle differences below the age of 1 year. Affection, so involvement of the arms and legs was much more common than in older children. And with age, involvement and flexion of the head and not so much of the trunk was much more prominent than in younger children. And these differences which were not so significant. Actually, the authors concluded that semiology of the spasm, presence and preceding of concurrent seizures, some periodicity of the spasm. This is subtle variability between these 2 age groups. They were not clinically very dramatic, except probably this unresponsiveness and behavioral arrest, which was more common in group of children less than 1 year and not so common in older children. It was especially characteristic for crying, which was more common in babies in comparison to older children in the group after the age of 1. Such seizure type, the spasms and also myoclonic seizures were also quite typical for the probably rarest type of epilepsy in childhood, the insular or insulo-percular epilepsy. Also in this type of epilepsy, quite specific spasm and myoclonic seizures prevail initially. Then neurovegetative sign can be seen, but also asymmetric tonic and hypermotor seizures. And autonomic symptoms are very peculiar, and they need to be seen because like strange reaction, arrest or suffering, or flush, cyanosis, apnea, and change in cardiac rhythm are very important because of impossibility of the children to describe their semiology, which is quite important because of early onset of children. Not all of them can be verbal and can describe what they feel, but still in this age, again, insular seizure onset must be suspected mostly in children who present with semiology of frontal lobe epilepsy. In older children, this is the hypermotor seizure and also the tonic seizure. This is a very nice study done again by collaborators of Hans Ludes and Guadalupe Fernandez. It was published 2018 and it even award by Epileptic Disorder Journal. They studied more than 250 patients in all age groups. As you see, there is a peak after the age of 10, but still one peak in the very early childhood age. So they found that focal epilepsy was usually more frequent in patients after the age of 10 years. And there is a gradient in the epileptic zone in children, because the most frequent in epileptic zone in patients from 1 month to 3 years is the undetermined, then the posterior one prevailed up to the age of 3 years. Between 3 and 6 years, so it's the school age, the temporal preschool age, temporal epileptic zone prevailed, and in frontal epileptic zone, so the anterior one is in the school age from 6 to 10. After that age, usually the most frequent one, epileptic zone, was of temporal lobe origin. And these are several graphs demonstrating the most frequent seizure and seizure component. These are patient age 1 month to 3 years. As we already saw, these are generalized epileptic spasm, myoclonic and hypomotor seizure prevailing, usually of undetermined or generalized EEG. In the next age group, 3 to 6 years, these are the generalized myoclonic seizures, again of generalized EEG, focal tonic and generalized tonic or clonic seizures, which more focal epileptic zone, but still it could be undetermined. And in the age of 6 to 10 years, auridialectic seizures similar to psychomotor or temporal lobe seizures, but also focal tonic and clonic are seen, and already in this end they could be a focal EEG, but also with generalized, and these are corresponding probably, not probably, but also to absences. In older children, so in adolescents, the picture is very much resembling to adults. Focal tonic or clonic seizures versus and generalized tonic clonics, already with well-known, well-seen focal epileptic zone, or in some cases undetermined. And interesting, they found that the youngest patient which was able to report an aura was at the age of 6 years. Classical automotor seizure was observed in a child of 3.5 years. And usually this patient less than 3 years have generalized but simple motor seizures and hypomotor, already many times mentioned, and these are the seizures of generalized nature, spasms, tonic or clonic seizures, which were found to be quite rare after the age of 10. So seizure semiology in EEG for sure reflects the maturation of the cortical function. And I would like to conclude also, because there is an Armenian name here collaborating with Hans Luders with this main finding and overview of seizure semiology and its value in all ages, not only in children. We have to remember and not to forget that seizure semiology is the manifestation of symptomatogenic zone, its activation. So it could start elsewhere in the brain, in the epileptogenic zone, but then the symptomatology comes from the symptomatogenic zone. So it's not covering or not correlating to the epileptogenic region. Not infrequently, we can see in a seizure conflicting, controversial lateralizing or localizing. So every seizure and every sign is important because we have to study its sequence, and also the importance of each sign is determined based on its specificity and the appearance during the sequence of a seizure. And also seizure semiology is becoming more complex with the age. And also, as we saw, not only because of the example of epileptic spasm, generalized motor seizure can be related to a focal epilepsy. Very important, there are some seizure types like focal, clonic, and tonic, as in adults, also in children, then they always lateralize to the contralateral side. And especially in infants, some very focal side like sustained diversion. But when this is alone, this is not a reliable lateralizing sign. So again, to emphasize, and we know it quite well, and use it every day in epileptology, video EEG is the only tool to properly observe, evaluate, understand, describe, and correlate any seizure in any age, especially in children. Thank you very much for your attention. And I'm ready to take questions, if any.
Thank you very much. I'll leave the questions at the end of this session. Next is Dr. Alin Herlopian. Dr. Pavlian, would you like to present our next speaker? Oh, I can do that. Dr.
Շնորհակալություն։ Այժմ ես ցանկանում եմ ներկայացնել հաջող բանախոսին դոկտոր Ալին Հերֆլոպյանին։ Դոկտոր Ալին Հերֆլոպյանը բժշկական կրթությունը ստացել է Բեյրութի ամերիկյան համալսարանում։ Նա ավարտել է նյարդաբանության օրդինատուրան Արկանզասի բժշկական գիտությունների համալսարանում եւ ստացել է երկամյա կրթություն կլինիկական նյարդաֆիզիոլոգիայի եւ էպիլեպսիայի մասնագիտությամբ Մասաչուսեթի գլխավոր հիվանդանոցում։ Նա ներկայումս Յեյլի համալսարանի նյարդաբանության ասիստենտ պրոֆեսոր է, մեր դասակարգմամբ դա դոցենտի կարգավիճակն է։ Խնդրեմ, Ալին, ներկայացրեք ձեր զեկուցումը ցնցումների սիմնոլոգիան մեծահասակների մոտ։ Մենք հիմա լսեցինք դոկտոր Զիմովային երեխաների մոտ եւ հիմա մենք կլսենք դոկտոր Ալինին, նա կներկայացնի նույն սիմնոլոգիան, բայց մեծահասակների մոտ։ Խնդրեմ։
Thank you, everyone, for this generous invitation to join my colleagues in Armenia and around the world in sharing the latest in our field of epilepsy. I'm going to be talking today about the semiology in the adult population. I have no disclosures. I'm going to start with the concept of epilepsy, how it evolved from the concept of zones to network, and finally we're going to give cases that's going to elaborate certain semiologies, particularly the focal in the focal epilepsy. We're not going to address or delve into the generalized seizure types. So what is epilepsy? As noted here in the illustration, you have the picture A and picture B, where you see different presentation of what constitutes what represents or what describes what epilepsy is. In the past, we used to think that there is a hypothetical zone that you have to resect enough tissue from that epileptogenic zone for you to attain seizure freedom. This zone includes, in addition, symptomatogenic zone where it causes the symptoms, the ictal semiology. You have the epileptogenic lesion, and also the focus where the seizure started from. However, over the years, and especially with Dr. Susan Spencer, our concept of epilepsy has changed. And now we talk more about networks. And the reason why that's more relevant in the current practice is that with the newer devices, with the newer generation neuromodulatory devices like responsive neurostimulation or deep brain stimulation, and with also the newer neuroimaging techniques, we now know that it's more of a network theory rather than a just small focal area in the brain. So, for example, you might have a hub or a node that might be instigating the seizure, but at the same time, this node might be connected to other nodes in the brain that might be in the vicinity or in the remote, and those can have variable degrees of connectivity, and those can be all of them involved in the seizures. So that's where our concept currently is, and there are more emerging data that corroborate this hypothesis. So case one, just to show you how we have focal findings, but overall we have a global or regional network problem. So this is a 57-year-old patient who has very focal seizures that progress to bilateral tonic-clonic activity. Over the 2 years' time, his epilepsy worsened tremendously. He was swinging between periods of repetitive cluster seizures, where he could have multiple seizures per hour, up to periods where he was in non-convulsive status epilepticus, and at times with focal motor status epilepticus. He failed all anti-seizure medications, immunotherapy, plasmapheresis, everolimus, which was administered because of a genetic mutation, DAPDC5, and also the biopsy, finally, a biopsy showed that there is a left hemispheric Rasmussen encephalitis and focal cortical dysplasia. So what is the semiology? So let's dissect it for this patient. So there are 3 seizure types. So first, you have the déjà vu, sense of being in a dream, and this dizziness, as if he describes as I'm fading out of sensation, I'm fading away, and he loses awareness. Looking at the semiology, it doesn't seem to have much of a lateralizing value, although that's not the rule, but sometimes you see déjà vu most likely associated with non-dominant hemispheric seizures, but it localizes mostly to the mesial temporal. Looking at his second seizure type, we see that there is the teeth. He reports teeth and his gums are becoming sensitive. The throat is itchy. Then this progresses to right-sided facial clonic movement, goes down to the neck, arm, and finally the leg. And post-ictally, he has right-sided weakness as well as excessive secretion in his throat, and his voice becomes weak. So looking at the sequence of events, mapping a trajectory, you would say that the seizures are likely from the frontal opercular area or the insula as well. And they progress and they march towards the primary motor area in the left hemisphere, specifically involving the facial representation, the moving more medially from the lateral to medial side, involving the neck, the arm, and finally the leg. The third seizure type is speech arrest. He comprehends, but he's unable to utter words. He has severe expressive aphasia, and post-ictally, he gradually starts to regain his language, and he has marked naming deficit. This puts us into the frontal dominant operculum, and because it's mainly the speech, and unlikely the comprehensive center in the temporal lobe, where you have the comprehension center. So this is the seizures, how their seizures look. As you see on the quantitative analysis, you see all these per hour. He has multiple seizures per hour. And this is the MRI. As you see here, there's hippocampus sclerosis on the left. You have some thickening of the cortex in the angular gyrus here, the possible dysplasia. And then finally, you have increased signal, the gray-white matter junction blurriness in the opercular area. And then you see this is on the volumetric analysis. You see this area is thicker in the opercular region and the insula compared to the other side. So basically with this patient, you see it's a broad, although you have certain areas of semiology that are involved, but they are in different anatomical locations as well. So it's probably multiple areas of ictal onset. So this is at the start of his epilepsy, you see a nice language mapping. All these areas are involved in the language task where he was able to perform expression, he was able to talk, and it was he was okay. This you see there's loss of language. Over the years, the tractography also shows that he has impairment. You have loss of signal. This is the start, and this is 1 year. Basically, the green, it means that there are tracts going from the anterior from the posterior to the anterior part of the brain on the anterior axis. You have the red goes to the from the lateral to medial or medial to lateral, and then the blue is just it's the marches down towards the brainstem. So if you see here, there is loss of signal in this area, which means that the tracts over time are being affected not only by his disease process as well, and also epilepsy can also be part of the etiology. So this is the PET scan during his seizures. You see the hypermetabolism in these areas. It's in the frontal area, specifically here in the frontal opercular region. This is the subtraction PET where we use that between the ictal and the interictal, and you see it's a broad region. So how do you treat this patient? If this is a dominant hemisphere, you cannot perform resection or else there would be a compromise. So we implanted it with deep brain stimulation. So the reason why I brought this up is because Now with the era of neuromodulation, we're targeting the thalamus. So now we're talking about networks. We're not talking about mainly specific zones. We have a broad network where we're trying to modulate and trying to affect and subsequently attain seizure freedom over the long period of time. This is the area of the anterior nucleus of the thalamus. We have bilaterally implanted. This is the CT where you have the depth electrodes. And this is an interictal activity, which means that there are spikes we're seeing from the left thalamus. This is the right thalamus. As you see here, there are spikes that we see. And then here, this is a seizure that we see when the patient is having clinical seizure. The thalamus also records a seizure. As you see here, the seizure evolves, and then it's evolving, and then it's becoming more rhythmic. So the thalamus was not part of the lesion. However, since we have lots of connectivity with the limbic system, the frontal lobe, so we have it involved, and that's where our concept of epilepsy is changing and evolving. And as you see here, there's more activity in the left, and there's no activity on much of the right side. So what is semiology? Semiology is a clinical manifestation of a seizure. It's the byproduct of a dynamic interaction between different parts of the brain, nodes and hubs within an epileptic network to cause the semiology. Now, semiology is a crucial key of evidence for localizing, lateralizing seizures, trying to see where exactly that part of the brain is involved in producing those symptoms. However, it doesn't necessarily mean that that's where the seizures are starting from. It might simply mean seizures start from an area that's very close or in a remote area, propagate to that specific region, and hence result in the semiology. So that's called the ictal propagation activation of that area to cause the semiology. So what are the types of seizures? As mentioned, generalized and focal. We're going to address here for the focal seizures. Now, I try to categorize the areas, the lobes of the brain, into their territories where they can produce different symptoms. So, and as you note here, we have the insula. In the past, we never addressed the insula, but over time, we found out that most of the failures that we're having in the surgeries, and we're assuming it's probably frontal or probably parietal or even temporal, the main ones are the temporal, is secondary to an unexplored insula. And now we have more of, we're exploring that area more often and more diligently. So dividing the lobes, we have temporal, frontal, insular, occipital, parietal. The temporal, the reason why it's divided into mesial and lateral, because the semiology manifestation when seizures arise from specific areas differ. And we're going to address that in a bit. Frontal, we have the prefrontal part of the brain. We have the frontal operculum, as we saw in this prior patient where the language was involved in the dominant hemisphere. The frontal eye field, that's where you have the gaze deviation with the versive head deviation, the primary motor cortex, the premotor, supplementary motor area. And as we saw in the prior patient as well, we had it involved with specific manifestations. The anterior insula, the posterior insula are totally different. Occipital, medial, lateral, infracalcarine, and supracalcarine. Infracalcarine and supracalcarine are a bit different simply because it depends on the propagation pathways. And again, we come to the concept of network. If the seizures are infracalcarine, then they can propagate down to the temporal lobe and cause different manifestations. If the network goes from the supracalcarine pathway, then we would have different manifestations like parietal frontal manifestations and more of motor features. Parietal, also is similar to the priors. We have the inferior parietal lobule, superior parietal lobule, and we have the primary sensory and secondary somatosensory cortices. Always keep in mind with the semiology, when you read a paper, there are lots of papers out there. They talk about semiology and localizing it to this area, frontal lobe. So make sure that whenever you read those papers, you understand that they also have been associated with the seizure freedom, which means that if a semiology has been attributed to the mesial temporal, okay, Did they study that in postoperative patients? Did they study that in patients who attained seizure freedom? If the semiology is coming from the mesial temporal area, they resected it, and the patient has attained seizure freedom, then yes, you can confidently say that the seizures are attributed to that area. However, if you do the resection and the patient does not attain seizure freedom and they have persistent seizures, then we should always question the validity of a particular semiology to be pointed to that particular area of the brain. And when I say that, I want to bring the simple example of gelastic seizures. With gelastic seizures, when they performed surgeries on temporal lobectomy or frontal lobectomy, the patient persistently had seizures, simply because the main area that was triggering and causing the seizure was the hypothalamic hamartoma. So that's what's important when we look into semiology, to assess their relation with the outcome as well, to confidently say this part of the brain is likely associated with this semiology. So what are the most important key semiology features that we have to look for? Fear, panic, most likely mesial temporal, anterior cingulate, anterior insula, and to certain rare extents, the prefrontal and the orbitofrontal area. The reason why it's probably less likely is probably there might be a propagation from the anterior to the from the anterior insula to the prefrontal area, and hence we sort of attribute it going into that region. Autonomic feature is mostly sometimes comes from the insula, the temporal lobe, mesial prefrontal. Experiential phenomena is usually this deja vu-like feeling, or the complex visual hallucinations, psychic manifestations. Usually they point to the temporal lobe. The most important also is the deja vu, the jamais vu, all these memory-related manifestation. They point to the mesial temporal area, the entorhinal cortex, and less likely to the anterior insula. Anything that's laryngeal, anything that has bilateral presentation, let's say chest, torso, along with sensory manifestation, is usually in the opercular insular region, posterior insula, and the parietal opercular region. Tachycardia, insula, and the temporal lobe. Hallucinations also has to be divided. If it's a simple auditory hallucination, it's likely the primary auditory area, which is the habeas gyrus. If it becomes more complex, then it's the temporal neocortex. You have the illusions of the body, somatic illusions, vertiginous sensation. Those all point to the inferior parietal, temporal parietal junction. Visual illusions, otoscopy, macropsia, all these point to the parieto-occipital area. Importantly, the visual fields. So if you have a primitive visual manifestation, flashing lights, let's say flickers of lights, colors, those are most likely to the occipital lobe. And if they become more complex, they have, you see, for example, some patients say, I saw a castle. They all point to the temporal lobe or the temporo-occipital area. Automatisms, they usually unlikely have a lateralizing or localizing value. Usually they say mostly temporal, or in certain rare instances, the orbitofrontal area. However, the most highly lateralizing feature is the manual automatism, that is ipsilateral to the seizure onset, associated with contralateral dystonic posturing. That's mesial temporal lobe. And the reason why we have ictal dystonia is because we have ictal recruitment of the basal ganglia. And lastly, the most prominent is the hypermotor gestures that point to the prefrontal cortex, like kicking, bicycling, pedaling, pelvic thrusting. Aphasia points to the dominant frontal lobe, dominant temporal area. You have the versive head turn. So if it's early on, versive head deviation, it has to be in the frontal eye fields, which is the posterior part of the middle frontal gyrus, and anterior to the premotor area, contralateral always. Motor movements, tonic, clonic, is always contralateral to the ictal onset. And finally, you have these other sensory manifestation is always contralateral to the primary sensory cortex. So let me give you some examples to go over the cases. We have a 26-year-old patient who had a seizure of the type déjà vu, swallowing movement, which are the oral automatisms, nonsensical speech, which means that it's not ictalophagia. He was able to speak words that are clear, but they were out of context, and that pointed to the non-dominant hemisphere, fumbling with the right hand, which also puts it to the ipsilateral side, and you have left hand shaky movement, and this is what we call it ringe, which is non-rhythmic, the non-clonic tremors of the contralateral hand to the ictal onset, and sometimes stiffening of the left hand, which is the dystonia, and also again is contralateral. So if we're going to, and lastly, the other part is the wiping of the nose with the right hand, which is usually a post-ictal phenomena associated with ipsilateral focus. So if we're going to localize and lateralize, we're going to say lateralizes to the non-dominant right hemisphere and localizes primarily to the mesial temporal structures. So looking at the mesial structures here, the hippocampi are normal. Intracranial monitoring, we see here the seizures start in the hippocampus in the right side, as you see here, and then they march backward and downward, producing the different other manifestations. So the seizure's clinical manifestation starts at the red dot. As you see here, the seizure started, propagated, and caused the semiology. Now, surprisingly, our patient had also left-sided seizures on this side. So as you see here, but those did not have any clinical correlates with it. And this is not uncommon for patients with temporal lobe epilepsy. So then we stepped back and said, so this patient has right-sided seizure and left-sided seizures. The left were silent. In real life, what is he going to experience? So that's why the decision was made to implant him with a device. So this device, we call him the responsive neurostimulator, where you see there are electrodes directly going to the hippocampus. And as you see the electrodes here, they're in the hippocampus and in the amygdala. So basically, these record the seizures. So the idea is both diagnostic and therapeutic. You see here, the right hippocampus is causing most of the seizures. So as you see here, the right side is seizing, here, while the left side is not seizing. So the idea from this approach is to have a recording of the patient's real life seizures, to quantify them, to see if the left side is also causing seizures. Because if the left side is also causing seizures, then at this time, what we're going to do is we're going to either continue with the stimulation as we're doing here. The TX is giving treatments to every seizure that the patient has, or if there is only right-sided seizures, then we are going to offer him a resection of the right side if all the disabling seizures are proved to be right-sided seizures. This is another case, as you see here, in the temporal pole. The temporal pole is the anterior most part of the temporal lobe. It's in the neocortical region, and it has high connectivity with the hippocampus. So if you see the symptoms, fear, depersonalization, oral and bimanual automatism, tachycardia, those all point to mesial temporal manifestations. However, the seizure starts from this area, propagates to the hippocampus, activates it with the ictal pattern, and causes the manifestations. So if you see here, we did the scalp EEG, it was right-sided seizure. And on this patient, what we did is basically we offered resection of the cavernoma in that area, and the patient has been seizure-free. So what was happening is that the patient had neocortical seizure propagating to the mesial area, producing the symptoms. Removal of the cavernoma caused the resolution of his symptoms. This is another patient we have, where we have the, as you see here on the right side, we have a thickening of the cortex. As you see here on the right side in the frontal opercular area, we had a thickening of the cortex and also some thickening in the insula as well. As you see here, this is the premotor region, where you have thickening of the cortex involving the facial area. And why is it important? That piece of information is because of his symptoms. So he has two types of seizures. One nighttime seizure, wakes up, has this unusual aura where there's a rush into his body. There's the gasp, he gasps for air, and has some quivering and spasm of the throat. If you want to localize this points you towards the insula to the opercular area. This is the type of manifestation that we have it from that region. The second manifestation is inner sensation in the left lower face, sometimes in the mouth, the tongue, and then he gets left-sided facial pulling. Left shoulder and trunk twitches, and rarely progresses to bilateral tonic-clonic activity. Localization is, again, left with going to be contralateral, which is the right-sided lower face, and then it marches upward gradually, following the homunculus, and goes from the face to the arm to the shoulder area, and then it is by hemispheric propagation. As you see here, the EEG, MRI manifestation corroborate all are concordant, and they are congruent findings. You see here, it's all on the right, centroparietal, mid-temporal, and central region on the right. This is the intracranial EEG. Now, if you see here, roughly speaking, the lesion is around this area where you see it with the yellow circle. And the areas that are, this is where the seizure starts. And those are the nodes or the areas that are recruited. And those are the areas where they produce the symptoms, as you see. So the seizure starts from here, propagates, and produces those symptoms. So what we have done for the patient, now this is very critical, this is a motor area. So we cannot remove this area, although it's a right hemisphere and there's no language in that area. But since there's motor, we map the area, we draw the margins of the resection, and we ensure that the ictal onset area is involved in this. Those areas are for the critical for motor function of the hand, okay, and the arm. So we excluded these areas, and then this is the resection cavity. So last, we're going to talk about the parieto-occipital types of manifestations. A patient has flickering in his eyes, flashing lights, both visual field, his perception changes, has palinopsia, where pictures recede in an alternating direction, and they have oscillation but no movement within the eye field. So all these manifestations, you see there's primitive visual and some movement to the vision. So this points to the parieto-occipital area. Then as you see, the manifestations progress into oral automatism, left-sided non-forceful head turn, and then he goes into right-sided non-versive head turn, then progresses into bilateral tonic-clonic activity. So all these movements in the head, usually we say, because they are later in the seizure, it might not have a highly lateralizing value. However, the most important would have been a versive head turn. Versive head turn is usually contralateral, and we don't have this. One would assume in this way and say, possibly the seizures are propagating from that region that we have it into the bilateral temporal area, and hence we have all these manifestations. Okay, so this is the MRI. You see here that you have the cortex, the neocortex is thickened in the parieto-occipital region, superior occipital, inferior parietal, and it's a quite broad region. So we investigate that area to ensure that we know the margins where we're going to resect, especially that the semiology is rapidly progressing into bihemispheres. So if you see here, this spikes start from the occipital area. That's where the depth electrode is in this region. We implanted this area. So spikes start from there. And as you see, it becomes maximal, and the symptoms start here, which if I magnify it, it shows that there is a progression into most of the temporal frontal channels in the brain. This is the frontal part, and those are the temporal channels. So the seizure spreads out from the occipital parietal area down to the temporal and up to the frontal. And that's why it causes all these multiple types of manifestations. So as you see here, this is the onset, and it marches in the brain in different directions. And those are all contingent upon the connectivity of the brain. So the patient had a resection. This is the focal cortical dysplasia, the dysplastic neurons, and this is the region of the dysplasia. So what is the take-home message from this, from our presentation? Semiology is a very important key that helps us to lateralize and localize. However, we have to keep in mind, it does not necessarily mean the area of ictal onset. It might simply mean that it started from an area and propagated, activated, causing the symptoms. Always, when you're reviewing your seizures or assessing an epilepsy patient, you have to know your anatomy, you have to know your network, and you have to know your tracks. And finally, the most important thing, that as we are evolving in our concept, the thalamus has become now an important anatomical location where we are targeting it to modulate the networks in the brain to stop the seizures and hence to have a better outcome. I want to thank my collaborators who have helped me with all these cases and my team at Yale University. And thank you everyone for your time.
Thank you very much. Wow, excellent presentations from both. I'm going to move to the question and answer section. I have a few questions from the audience, and I will continue looking at them and translating them to English for both of you. And I also have some questions of myself, if you don't mind. First, Dr. Janeta Gevorkian has asked a question. If you could please explain the genetic and hereditary roles for pediatric seizures when there is a manifestation in adulthood for the parent. This question, Dr. Dimova, is for you.
Sorry, but I didn't realize, probably not heard well. What to explain?
The question was, Janeta Gevorkian asked, if you could explain the genetic and hereditary role if the parent has started their seizures in adulthood.
I'm not sure that I can explain, and I'm not sure that a lot of specialists in epileptology, they could explain why some seizure manifest in adulthood, as if I understood well the question, even if there is a genetics. Of course, this change in the brain and the development plays a huge role. And we know that there are a lot of mutation in specific gene, and epilepsy is even focal and lesional related to those mutations, manifest not early in our life or patient's life, but later on. And I'm not sure that this can be explained very easily, because some of the genetic mutations, they are related to some ion channels, some other to more complex cellular features. So it's quite a difficult question, and I'm sure that there are development in the science which can probably soon explain why it's this happening.
The question I have, Dr. Dimova, is if you could explain the transformation rate reduction from spasm to generalized, and what does that have to do with that age out of regular age for that semiology?
Spasms are quite simple seizures, but I mean, semiologically, they are usually seen in the early childhood age, but for sure they can persist. And for me, most important things is related to spasm is that they can be found in generalized genetic syndromes, but also in focal, and it's very important to observe the features related to the spasms and also to correlate. But for sure, this is a seizure types more related to a younger age of the brain, so to the developing age. Also, for sure, there are many patients having focal epilepsy manifesting even later in life, and persisting seizures, which also can be a spasm or a seizure manifestation. For sure, spasms also involve a big network, also as explained by the second speaker, basal ganglia, and a lot of regions in the brain. So this is a simple seizure, but quite complex in manifestations.
Thank you. Dr. Housepian, for the examples that you mentioned, will that cross over, even though in the hypothalamus there was no recording at first? Is the timing of the manifestation of the seizure on the contralateral side, is it a measure of success in surgical treatment?
So that's a great question, and it's very infrequently explored. So propagation, the latency to propagation. So just to step back first. So when we're doing the intracranial monitoring, you're sort of narrowing your view. You are targeting a particular area. So you're not sure exactly what's happening in the unsampled area. So now going to the sampled places where you have it, we often talk about latency of propagation. So the shorter the latency is, the likelihood of the unfavorable outcome is higher. The longer the latency, the better the outcome is, because sort of you would say, well, it takes time for it to propagate to other sides. Now, there are other factors involved as well when it propagates to the other side, which we often see as a new ictal onset pattern, which means if you have a seizure coming from the right temporal area, 10 seconds later, it's in the left temporal area, you have to make sure that that other side cannot generate a seizure after you're resecting the right side on its own in the future. So there are lots of factors, and true, latency is not that studied, but the timing of latency, usually we say the best one to sort of come with a favorable outcome is 10 seconds.
So the cutoff is at 10 seconds, meaning that after 10 seconds, yeah.
Yeah,
okay.
So 10 seconds from the onset in the temporal lobe cases. So we don't have much data on the frontal lobe because it's a more extensive lobe. We don't have much data on the parietal occipital, but usually temporal lobe cases, we do say that 10 seconds is a good cutoff if it starts propagating outside the temporal lobe within the same hemisphere.
Excellent. The other question for you, you gave an example of the temporal lobe excision intraoperative monitoring. Was that done awake? And was there a monitoring intraoperatively, like motor monitoring during the awake?
So usually the awake is for the so we barely do any awake intraoperative monitoring unless you're going to test for language. But again, testing the language in the dominant temporal lobe, it's very limited intraoperative setting. That's why we often rely on extraoperative mapping if it's a dominant temporal lobe cases. Any intraoperative, if it's motor mapping, it's usually under sedation, but lightened sedation of the muscle relaxant just to make sure that there's motor movements. And also you would do the ECOG, which is the lightened sedation as well.
Thank you. Going back to pediatrics, any relations in the outcome regarding age of the start of epilepsy? And particularly the examples that you gave, Dr. Dimova, of a typical age of a start. If there is an epilepsy that starts out of that regular age, a common age, is that dependent on the outcome?
I think in general, the childhood epilepsies, especially those who are operable, they have a much better outcome than the adults. Of course, we are always aware if, and so to say, frightened if epilepsy has a very early onset, especially in babies, so below the age of 1. But even in this age, if there are severe seizures, but still related to a focal lesion, can be cured. So in general, I think, because I'm also doing adult epileptology, the children, if they can be operated, they have a much better outcome than adults. Of course, if, let's say, spasms start later, which is unusual, it could be a sign that this is not a simple network. So even just a small seizure can bring success, but the removal of a lesion. But still, there are some uncertainties in such cases if the disease development and also the exam are not typical and not classical in correlation for easy operation and straightforward surgery. And of course, genetic epilepsies with early onset, that they are much more complex and much more difficult than early epilepsies with focal seizures and the lesion.
I'm still waiting to see if more questions come in, but I have a question for both, and if you could answer, and that's the relations of dominance. Now, in pediatric population, the focus of epilepsy being on the dominant side or not, would that affect the psychomotor development or not?
Of course, but it also depends on age, because we have, and I think many of the colleagues have cases with dominant left hemisphere, and if we remove the lesion and if you cure the patient or remove the process, even in Rasmussen cases, then the psychomotor development can be improved. We can observe a shift of the language. So afterwards, except for the motor deficit, the development could be quite normal. And especially in such big lesions like the porencephalic cyst with the post-ischemic or post-hemorrhagic origin, there is a huge trend for improvement for such children if they are operated, and even if it's early and not late during the disease course. So even if this hemisphere seems to be dominant, if we remove the epileptogenic zone and the child becomes seizure-free, then the chance to have a normal psychomotor development is much bigger if the epilepsy persists and the child is only on drug.
Aline, what would you say that?
So for the development of dominance, we have accrued data from functional fMRI and other testing as well that shows us that even if non-epilepsy cases, stroke cases on the long, let's say, even if they're adult, there is some sort of reorganization of language intrahemispherically. So what that means, if, let's say, you have a pediatric onset epilepsy earlier than the age of 6 or 5 years, there can be a shift to the contralateral side. So the dominance changes. So it becomes, it doesn't become a matter of left or right or handedness. There you can see a shift. In the adult population, we often see that as well. There might be a shift, a reorganization. Language changes itself. If it's a late adult onset, you might see intrahemispheric reorganization. And sometimes you might see on the contralateral side. This we're talking about simply language. If you have the verbal memory or the visual memory, that's also a different situation because it depends on the chronicity of epilepsy. It depends on how active the seizures are. And sometimes when your brain is actively seizing from the dominant side, the other side gets affected. So the scores of visual memory drops on that side. And the dominant temporal lobectomy in a very poor memory function can have a release phenomena, which means the other side gets liberated and the scores improve.
There are questions. I'm going to take a look, but again, one question for both. How is the transition of care from pediatric to adolescents to adult? Because I see this different in different hospitals, different medical centers. What is the collaboration between the pediatric, adolescents, and adults? Let's start with you, Dr. Dimova.
Okay, yeah, if I have to share my experience, and this is not personal, but actually national experience in my country is quite poor. Not to say that my patients are happy, but because I'm doing both children and adults, I can care for such patients after their childhood, after the adolescence, so I can follow them and treat them and think to do everything what they need. But in general, this transition is very poorly organized and collaboration is not good. This is one of the efforts of our National League Against Epilepsy, but because of huge problems in the organization of the epileptology care in Bulgaria, we face big problems, which is poor and quite bad.
From my experience and in the region as well, we do have a transition clinic where it's sort of when they're 16 to 18, they start to transition. I would say this from my short experience in the epilepsy, I think you have to divide your patient population that transitions from pediatric to adult into three categories. There is the group that has developmental malformations, like developmental cognitive delays, you know, they have their syndromic presentation, usually group home patients. Those have different requirements. Those, they need a comprehensive center where you need to follow them up. If they have a PAC tube, wheelchair bound, additional care. This is one category. The other category comes your generalized epilepsy type, IgE, JME, those patients, they're sort of already are probably well controlled. They just need you to monitor them. And then down the line, the question becomes, should you discontinue the medication or lower it for those patients? The other category is where you have focal epilepsies and with lesional malformations, say if you have a cavernoma, small low-grade growing tumor. So those are sort of, they merge or they blend into the adulthood. I think those are the different. The most difficult is for those who have Lennox-Gastaut or Dravet syndrome, or those are because they need a comprehensive collaborative approach between physical therapy. You need different domains to work together.
Social service.
Exactly. And in our state of Connecticut, here we are very blessed that we have the state also helps us with these, because we have all these multidisciplinary team lined up together. So we have a good sort of a plan for those.
I'm going to try and ask a couple of questions from our audience, which it seems that there are primary care or pediatricians, but still, I think
Ես
they're
4 հարց եմ
relevant.
գրանցել։ Դոկտոր Ավետիսյան, լսարանից ես ունեմ 4 գրանցված հարց։
Go ahead. I'm sorry. Go ahead. There are some questions in that I'm reading, but go ahead. Do you have a question?
Ժանետ Գևորգյանը հարցնում է, արդյոք կարող է հիվանդությունը փոխանցվել մորից աղջկան կամ թոռնիկին։
So, Feria, do you want to answer?
Go ahead.
So usually we talk a lot. Now there is an increase interest in epilepsy and genetics in epilepsy, and now we're sort of figuring out more of these genes, and specifically those genes that we call them variant of unknown significance. When we do these genetic testing for those patients, we are able to find those genes. But the question is, are these pathogenic? Do they cause the epilepsy per se? Now, there are certain cases, we know there is preponderance, there is proclivity for them to be inherited. There's a tendency, but there is no one-to-one ratio unless there are certain syndromes, for example, tuberous sclerosis. You have certain diseases where they can be transmitted. They have a specific pattern of inheritance. And there are, most of the time, sometimes it could be de novo. So it's very important to identify those diseases like tuberous sclerosis, if they are diagnosed in the family, to sort of counsel them and say, hey, there is a risk of you to inherit them. So might as well need a genetic counseling for that. Apart from that, the rest of the genetics, whatever we used to say in the past, we don't know. Now we're finding variants of unknown significance, and we don't know what to do with those genes.
Next question is about nursing in mothers with epilepsy.
So breastfeeding, in the past, we used to always say any person who takes seizure medication, we should not be allowing breastfeeding because there's the medication passes to the baby. But now there are recent data that shows that cognitive development of the babies, they are much better if we have nursing, we allow the lactation. That's why now our tendency is we encourage breastfeeding in women who are taking seizure medication. We caution them sometimes on the medication that they're taking, for example, clobazam or certain other medication that might cause a bit of sedation in the baby. Otherwise, breastfeeding it outweighs the benefits is outweighing the risks.
and which is the best drug for breastfeeding for a woman with epilepsy who wants to nurse her child? Which is the best drug? What do you think? Anticonvulsant.
Oh, the medication. So we sort of don't think about it like in the breastfeeding phase and that. We look at it in terms of the pregnancy per se. We have the levetiracetam, lamotrigine. Those are the best medications that we have. You have to keep always an eye on the levels though. We have some data on oxcarbazepine, zonisamide. We don't have the data on the cognitive development, but we have data that they are okay for the teratogenesis malformation wise. Newer drugs now are on the market, so I think more data is going to come out. We less likely tend to like the Topamax. We less likely tend to like the carbamazepine because they cause all these malformations and at high dose Depakote.
Just two quick more questions. One is about someone is asking if they should be able to touch a patient with spasm or not, because it's been known that not interfere with anything, stop it or not.
Again, I didn't understand fully the question. Should we
interfere, touch a patient which is in spasm?
Probably the question means
no,
let's stop it.
To touch during the seizure, you mean during the spasm? At the first, I don't think there is need a first aid. Of course, if it's a long series of spasm, we have to stop the series because this is a seizure. And so cluster of spasms is cluster of seizure. But still, if they are not so severe, it's not specific aid for the spasms, at least what I'm doing. And we have to aim to control quickly the spasms in general to suppress them, because especially in spasms going on with the hypsarrhythmia, this is a dangerous situation for the brain. So this is an urgent situation to interfere, not during the particular seizure or cluster of spasm, but the aim to cure the spasm. So to address the treatment, being it hormonal treatment or treatment with vigabatrin, and then to see what is the cause of the disease and to aim to cure the disease, which is going into a spasm for the child.
So one last question. I actually myself did not read, like I'm reading it, I don't understand, but I think it's about a long seizure. Maybe Dr. Bavlian, you can help me on this. It's also this, Dr. Shahan Mosisian is asking if a sclerosing of hippocampus the reason, and it's a long lasting seizure, more than 6 minutes. Is there anything for the treatment or not?
So so first of all, for just a simple first aid for a seizure, any person who has a seizure, technically seizures should stop between 1 to 2 minutes. So whenever the person has a seizure, just turn them on their side, nothing in their mouth, and the seizure would stop. Anything that goes beyond 3 minutes, usually we do say that we have to intervene with benzodiazepine. Different parts of the world have different interventions. Some they use rectal diazepine, benzodiazepine, like certain medications, and I tend to use the nasal spray. Any patient of my patients, for example, who have all these prolonged seizure or they cluster into a seizure, we usually tend to tell them, depending on the type of the seizure, to use the nasal spray. It's a benzodiazepine as well. So any seizure that is longer than 3 minutes, usually convulsion longer than 3 minutes, just give them if there's Diastat or there's the nasal spray. If it's any focal seizure that's lasting more than 5 minutes, you can have longer time to intervene for that. You can just use any benzodiazepine, and always make sure the mark is 5 minutes,
Thank you very much for both speakers. We're out of time. There are some more questions, and some of them I do see that they will be answered in the next talks. Like the treatment options and its success and so on and so forth, or vaccination as a cause. But if our participants would wait a little bit for the next lectures, the questions may be answered through that. Thank you very much again. We will have about 10 minutes of a break and we will come back. Dr. Sukudian and Dr. Khachaturian will moderate the next session. Thank you very much. Hang in there, don't move or move, but come back in 10 minutes. Thank you.
«1988 թվականի երկրաշարժից հետո Հայաստանին օգնության ձեռք էին մեկնում ամբողջ աշխարհից։ Արհավիրքը շուրջ 25,000 մարդու կյանք էր խլել, 100 հազարավորներին թողել անտուն ու անապրուստ։ Այդ օրերին Հայաստան հասավ նաև Միացյալ Նահանգներում ապրող մեր հայրենակիցների Թորգոմ arczepiskopos Մանուկյանի, Գևորգ Հովնանյանի եւ դոկտոր Էդգար Հուսեփյանի համատեղ ջանքերով ուղարկված օգնությունը, որ հետագայում հիշվելու էր որպես Հայ օգնության ֆոնդի ՀՕՖ-ի առաջին հումանիտար աջակցությունը Հայաստանին։ Այդ ժամանակվանից ի վեր Հայ օգնության ֆոնդը Հայաստանում եւ Արցախում իրականացրել է 300-ից ավել մարդասիրական ծրագրեր եւ բժշկական ծրագրերը 25 տարի շարունակ ղեկավարել է Կոլումբիայի Երիցական բժշկական կենտրոնի կլինիկական նյարդաբանական վիրաբուժության ամբիոնի պրոֆեսոր Էդգար Հոսեփյանը, զուգահեռաբար լինելով նաեւ ՀՕՖ-ի փոխնախագահը։ Այդ տարիներին դոկտոր Հուսեփյանը ծանոթացել եւ ընկերացել է նորանկախ մեր պետության առողջապահության առաջին նախարար պրոֆեսոր Արա Բաբլոյանի հետ, նախաձեռնելով մի շարք նորարարություններ ուղղված առողջապահության զարգացմանը մեր երկրում։
Գիտեք, երբեք դուք չեք կարող որևէ մի անգամ նկատեք, որ Էդգար Հոսեփյանը ձայնը կարող է բարձրացնել։ Նա միշտ խոսում էր այսպես շատ հանդարտ ձայնով, հանդարտ ոճով, այսպես, բայց բավականի հստակ եւ բավականի այսպես իմպերատիվ։ Այսինքն այդ իմպերատիվությունը գալիս է նորից եմ ասում, ոչ թե նա ինչ որ ինտոնացիա էր ընտրում, ինչ որ խիստ բառեր էր ասում կամ ձայն էր բարձրացնում, այլ գալիս էր նրանից, որ ինքը հիմնավորում էր անհրաժեշտությունը եւ շարունակական հետևում էր, որ այդ անհրաժեշտությունը ներմուծվի կյանք, որ դա իրականացվի եւ դա շատ բնորոշ էր Էդգարին։
Հայրենիքին օգնությունը Էդգար Հուսեփյանի համոզմամբ չպիտի լիներ միայն նյութական։ Նա ցանկանում էր այստեղ տեսնել բժիշկների այնպիսի սերունդ, որ մասնագիտական իր գիտելիքներով եւ հմտություններով հետ չէր մնա համաշխարհային առաջատարներից եւ ավելին կկարողանար կրթել նաեւ իրենից հետո եկողներին։ Հենց այդ նպատակով նա կազմակերպեց շուրջ 100 հայաստանցի բժիշկների վերապատրաստումը Միացյալ Նահանգներում եւ տվեց շարունակական մասնագիտական զարգացման միտքը։
Էդգարը շատ էր խոսում շարունակական բժշկական կրթության մասին, որը կարելի ասել, որ այսպես մնաց մեզ մոտ որպես ժառանգություն իրենից, եւ երբ որ ես արդեն ազգային ժողովում էի եւ ղեկավարում էի առողջապահության հանձնաժողովը, ապա ձեռնամուխ եղանք, որպեսզի օրենքի ուժով դա մտցնենք եւ դա կոչվեց արդեն շարունակական մասնագիտական զարգացման այդ նախաձեռնությունը եւ այդ ծրագիրը եւ օրենքի ուժով մենք դա կարողացանք այսպես հաստատել Հայաստանում։
Եվ ահա որպես երախտիկ մեծանուն պրոֆեսորին Արաբկիր բժշկական համալիրում հիմնվում է նոր նյարդաբանության եւ նյարդավիրաբուժության ծառայություն, կրելով Էդգար Հուսեփյանի պատվավոր անունը։ Մանկական նյարդաբանության, մասնավորապես էպիլեպտոլոգիայի ոլորտում հանրապետության առաջատար մեր մասնագետների համար ստեղծվեցին նոր հնարավորություններ զարգացնելու նյարդաբանության եւ նյարդավիրաբուժության այլ ճյուղեր եւս, իհարկե որպես գերնպատակ ունենալով էպիլեպսիայի ժամանակ վիրահատական միջամտության ներդրումը մեր երկրում, որովհետեւ մանկական էպիլեպտոլոգիական դիսպանսերում գրանցված 3600 պացիենտների 30%-ի մոտ հիվանդությունը դեղորայքակայուն է եւ նրանց կեսը ենթակա է վիրահատության։
Մինչև 2014 թվականը մենք համագործակցում ենք տարբեր երկրների հետ, Ամերիկայի, Կանադայի, եվրոպական տարբեր երկրների հետ, բայց հենց 2014-ին մենք 14-ից մինչ 16 թվականները մենք թվով 6 պացիենտ ուղարկեցինք Բուլղարիա, Սոֆիա, համալսարանական Սուրբ Իվան Ռիլսկու հիվանդանոց եւ այնտեղ նրանք բարեհաջող վիրահատվեցին եւ ոգեշնչված այդ արդյունքներից մենք որոշեցինք այդ նույն բուժման մեթոդը ունենալ նաեւ մեր երկրում 2016-ից մինչ այսօր մենք արդեն ունենք թվով 32 վիրահատած հիվանդ բարեհաջող մեծ տոկոս բարեհաջող թվով եւ Սկզբում այդ վիրահատությունները կատարվում էին տարեկան 1 անգամ միայն բուլղարացի գործընկերների ներկայությամբ, իսկ վերջին տարիներին արդեն մեր նյարդավիրաբույժը ինքնուրույն կարողանում է այդ վիրահատությունների մեծ մասը կատարել Հայաստանում։
Արդյունավետ վիրահատությունների հիմնական երաշխիքը որակյալ հետազոտություններն են, որոնք հնարավոր են դարձել լավագույն սարքավորումների միջոցով ձեռքբերված հավատարիմ գործընկերների օգնությամբ։ 2015 թվականից թիմը սկսեց իրականացնել 24, 48 և 72 ժամյա էլեկտրաենցեֆալոգրաֆիկ վիդեոմոնիտորինգ կարևորագույն հետազոտություն էպիլեպսիայի ճշգրիտ ախտորոշման համար։ 2021 թվականին առաջին անգամ Հայաստանում արաբկիրցիները կատարեցին WADA թեստ, որի նպատակն է նախքան էպիլեպսիայի բուն վիրահատությունը որոշել դոմինանտ կիսագունդը վիրահատության ժամանակ խոսքի, հիշողության շարժողական կենտրոնները չվնասելու համար։ 2022 թվականի սկզբին արաբկիրում իրականություն դարձավ գլխուղեղի խորանիստ ստիմուլյացիան շարժողական հիվանդությունների, այդ թվում պարկինսոնիզմի ժամանակ, կրկին առաջին անգամ Հայաստանում։
Զուգահեռ մենք ձեռք բերեցինք Edgar Housepian-ի ֆոնդի օգնությամբ մի բարդ սարք, որը կոչվում է Lexel Frame, որի միջոցով մենք պատրաստում ենք մոտ ապագայում նաև ներդնել ստերեո EEG, որը հանդիսանում է էպիլեպսիայի վիրաբուժության ամենաբարձր մակարդակի հետազոտություն։ Բայց արդեն նույնիսկ այսօր այդ ֆրեյմի օգնությամբ մենք կարողանում ենք վիրահատել շարժողական խնդիրներ ունեցող հիվանդներին, այսօր միայն 2 հիվանդ, երեխա եւ մեծահասակ, բայց շատ բարեհաջող այդ կուզենայի շեշտել, որովհետև որևէ դեղորայքային բուժում այդ հիվանդներին չէր կարող առողջացնել, իսկ այդ վիրահատությունը պացիենտների համար կրկին փրկություն էր։
Այսպես քայլ-քայլ առաջ գնալով էլ ընդլայնվում է արաբկիր բժշկական համալիրի Էդգար Հուսեփյանի անվան նյարդաբանության եւ նյարդավիրաբուժության ծառայությունը, բազմամասնագիտական իր թիմով չխնայելով ջանքերը հանուն պացիենտների առողջության եւ կյանքի որակի։
Ստեղ գյուղում ժողովարին ասին ով ուզում է սենց բաներ անի, ես էլ գնացի մասնակցեցի ու հետո դասընթացներ արինք, շահեց այդ ծրագիրը ու դա սկսվեց։
Բավականին երկար ժամանակ ընտրություն է եղել աշխատանքային process-ի մեջ ու դրա համար ես վերապատրաստման կարիքս շատ գոհ եմ եւ ինֆեկցիոն հիվանդանոցի բժիշկներից, ովքեր իմ վերապատրաստումով զբաղվում են եւ հոգի մասնագետներից։
Օգտվում եմ բարեգործական ճաշարանից եւ Հաճախել են իմ պապիկ տատիկը շատ վաղուց, 90-ական թվերից, լսել էր, որ հոգը բազմաթիվ ուսանողների աջակցում։ Մի քանի օր հետո զանգը ստացա, ասացին, որ շնորհավորում եմ, կանցել է քոֆի մարտիկյան կրթավճարը։
8 տարեկան երեխա էս տղես։ Ասма հայը պարտվող չի, մենք չենք պարտվել, մենք մեկը հաղթել ենք։ Դա ես երևում ունեմ հաղթել, պարտվել, պետք է առաջ գնանք։
Dr. Sohudan, you can start.
Yes. Hello.
Hello. I'm very glad to see you here. Now we will start our next session that will be about invasive monitoring and neuroimaging in epilepsy. My colleague, Dr. Samson Khachatyan, will introduce the first speaker.
Hello. So we are on air, yes? Hello, everyone.
Yes.
It's great to be here with all of them. And we will continue after this short break today's Clinical Neuroscience Symposium dedicated to Professor Edgar Housepian. And the next session will be full of interesting information as well. So the next speaker will be Dr. Dimitris Serletis, who is an epilepsy neurosurgeon scientist in the Charles Shore Epilepsy Center in the Neurological Institute at the Cleveland Clinic. He has his neurosurgery residency and PhD graduate training passed in University of Toronto, and he had his epilepsy surgery formal fellowship training at the Cleveland Clinic. Later, he had very wonderful experiences in establishing epilepsy surgery programs in different sites like University of Arkansas for Medical Sciences in Little Rock and University of Manitoba in Winnipeg, Canada. Had many awards also for this activity. And later on, Dr. Serletis joined the prestigious epilepsy team at the Cleveland Clinic, where he operates on adults and children with epilepsy and also directs the Brain Dynamics Laboratory. So Dr. Serletis serves also as a member and board member in different societies, especially in the Scientific Committee of the American Epilepsy Society and many other neurological surgeon societies. Professor Serletis, thank you very much for being with us. It's a great pleasure to introduce you. Please, the floor is yours. The topic is invasive monitoring in epilepsy, indications and techniques, please.
Thank you so much. I'll let them play the, we have a pre-recorded video that will be going live. And I'm happy to take questions at the end. I'll be here. It's a great privilege to be a part of this. Thank you so much. Greetings, hello, and thank you very much for the opportunity to participate in the Clinical Neuroscience Symposium in honor of Dr. Edgar Housepian. It's a great privilege to be a part of this conference, and thank you so much to the organizers for the invitation. Today I will be speaking about intracranial recordings, specifically implantation strategies and intraoperative monitoring. Here's a brief outline. So today we'll speak a little bit about the historical overview. It's always very important to see where we've been so that we know where we are going. And then quickly I will talk a little bit about the different methodologies for intracranial recording with a focus on stereo EEG, but I will also speak about subdural grids as well. I'll talk about the surgical workflow of stereo electroencephalography or stereo EEG, and I'll highlight a case example. And finally, I will present on future directions, looking at how are we using this data to guide epilepsy surgery. And this includes a brief overview of artificial intelligence and machine learning. I have no disclosures to make. Now, invasive EEG monitoring refers to the implantation and the recording of intracranial EEG. As we know, nearly 1/3 of patients with epilepsy are refractory to medications, and nearly half, if not more, of these patients are going to benefit from invasive EEG evaluation. The goals, therefore, are to not only lateralize, but also localize the epileptogenic zone, and at the same time allow us the ability to identify, possibly map, functional or eloquent regions prior to performing the resection. To speak a little bit about electrocorticography and subdural electrodes, this was pioneered by Dr. Wilder Penfield and Dr. Herbert Jasper at the Montreal Neurological Institute in Montreal, in Canada, in the 1930s to 50s. This is called the North American approach. And here you see Dr. Penfield and here Dr. Jasper, and they're working together, demonstrating the ideas of teamwork around epilepsy and the workup, as well as offering epilepsy surgery. They introduced methods for awake craniotomy, the ability to record from the surface of the brain using special electrocorticography tools. And ultimately, they were able to map interictal events and use this to help guide surgical epilepsy resections. This was very much a two-dimensional perspective, recording from the surface of the brain, but it was very important and made great strides towards our understanding of seizures and performing successful resections. These are some of the historical devices that Dr. Penfield used. You see the type of ball and probe device, which they would apply and rest very gently on the brain itself and record. And Dr. Penfield was excellent at taking careful observations and notes and outlines about each of his cases. And not only were they recording, again, the interictal activity, but also mapping out the homunculus and eloquent regions of the brain as well. And this gave way to the modern concept of the subdural grid, as you see it here. And of course, this approach requires large craniotomies, wide openings, opening the dura to permit the placement of these arrays of subdural grids. We can implant them on the surface, the convexity, on the basal surfaces, as you see in these images, in the interhemispheric fissure. And there are different arrays or configurations of using small subdural strips and so on. Great care must be taken to protect the large draining veins, of course, the arteries and the eloquent tissues shown here. And in this way, it could be performed at the time of surgery, as electrocorticography often is, which can help guide the resection of an epileptogenic focus, or alternatively, with a hinge craniotomy, closing the flap, the patient can be left in the epilepsy monitoring unit to record for several days or a few weeks afterwards, and allow for testing of eloquent function as well. And then moving ahead, we talk a little bit about stereoelectroencephalography, and this is the European or the French approach. And this was pioneered by Jean Bacot, shown on the left, and Jean Tellerac in the 1960s at the Sainte-Anne Hospital in Paris. And where they were different in their approach is that they looked at epilepsy as a disorder of networks. And Dr. Tellerac had developed the Tellerac frame, shown here, which allowed for very careful orthogonal stereotactic implantation of electrodes into the brain. And this was not a shotgun approach. Rather, they were guided by a very distinct methodology, combining knowledge of the patient's anatomy, the electrophysiology, and the clinical workup, the semiology as well. And again, keeping in mind the concept of epilepsy as a network disorder, they sought to implant the brain in 3 dimensions with these careful electrodes that could record activity not only over time, but also in space, which they called the spatiotemporal EEG. Dr. Tellerac is famous for many other contributions to society as well. One of the most notable was, and I present this to highlight how the stereotactic neurosurgeon viewed other problems of the day. During the Second World War, in his spare time, he would explore the tunnels and the catacombs under Paris. And you see where the access sites would lead him to different tunnels or different networks of tunnels, and he would explore them and eventually was able to connect them and make a map. And this map he gave to the Allies when they liberated Paris from the Nazis in the Second World War. And I show it just to give you an idea of the man and his mindset in terms of how he approached epilepsy as well, in a similar fashion in terms of networks and developing access points, which are the electrodes that they would implant to record from the brain. Dr. Tellerac's publications took a long time to make it into North America. largely because they were published in French. And so this is the first atlas. He developed the Atlas of Stereotactic Anatomy, where he developed cadaveric-based studies and introduced the Telerak frame and the Telerak grid as a referential system. And I'll talk about that on one of the next slides. And then he combined his methods with the neurologist, Dr. Banco, to introduce this book on stereo EEG for epilepsy. And then one of their colleagues who studied under them, Dr. Zikla, introduced angiography to further refine the implantation of these careful electrodes into the brain. This is a slide dedicated to explaining the Telerak grid. Dr. Telerak used pneumoencephalograms, and the anterior commissure shown here and the posterior commissure were easily identifiable on these scans. And he drew a line straight through them, which we call the ACPC line. And this was done to divide the thalamus from the subthalamic nuclei. And with the vertical lines applied at the anterior commissure in perpendicular fashion, as well as a posterior vertical line at the posterior commissure, we now see the beginning, the emergence of a referential coordinate system that Dr. Telerak liked very much because it could be applied to a brain of any size or shape without losing the proportional aspect for his implantations. So the anterior commissure is shown here on the sagittal view, and you see the posterior commissure here right at the tactile plate, just rostral to the cerebral aqueduct. And the anterior commissure is shown in this coronal section here as a band of white matter connecting the two temporal lobes. And here are some historical images showing Dr. Telerak with the frame, the patient on the table with the frame applied, the grid array that would sit at the side of the patient's head through which he would pass the needles, or the aiguille, as he called them. And down below you have the cadaveric studies highlighting the development of this frame and grid system. And one of the first images taken with the implantation now on the cadaveric specimen. And this slide is just dedicated to show to our colleagues that it's not simply a matter of putting electrodes into the brain, but also taking great care in doing so. These are Dr. Zikla's anatomical images showing the brain with the vascularity preserved. And here in the background, you see the grid array again from Dr. Telerak. And you see the concept of the referential grid on the surface of the brain and taking great care to avoid the blood vessels there. These are some illustrations from Dr. Olivier's book at the Montreal Neurological Institute, showing a more orthogonal style of implantation, which continues the French concept, and we adhere to that as well here at the Cleveland Clinic. This image could be refined a little bit. You see again some orthogonal placements. We tried not to go through the crown of the gyri. The trajectories of these electrodes should pass in more orthogonal fashion, parallel to one another as best as able, but also to capture as much of the gray matter and the deeper parts of the sulci as possible. This was performed, of course, with the Telerak frame. Others have gone on to introduce other Cartesian coordinate systems, or the Lexel frame, as shown down here on the bottom left. And nowadays, this is performed with robotic stereotactic navigation as well, which has made for a very accurate, very safe, and fast implantation procedure. We use the robotic stereotactic apparatus that you see here, the assistant, but there's also the Renishaw device as well out on the market, and they are all equally good. In terms of indications for stereo EEG, I was very fortunate even 10 years ago as a fellow at the Cleveland Clinic to contribute in a small way to this literature, but this has exploded now, and there are many more indications for SEG. But keeping it simple, we use it for performing a very nice three-dimensional sampling of epileptiform activity. Secondly, for patients with non-lesional MRI, it can be very useful. Targeting deeper structures, part of complex networks, such as the mesial temporal lobe, the cingulate gyrus, the insula, the orbital frontal region, particularly the posterior orbital frontal region, and finally the subtle focal cortical dysplasias that may be seen at the depths of sulci, where it's very difficult to place a grid. In patients who have failed invasive studies using grids, SEG has opened up a large opportunity to treat patients who were previously missed. And so this is now a good indication as well. And finally, in patients with multifocal seizure onsets and in performing bihemispheric explorations, SEG can be very helpful, very useful. Our surgical workflow consists of these images effectively, and I'll walk you through them, and I have some video. This is the implantation map, and at the patient management conference, the neurologists and the neurosurgeons and other team members will work together to recognize a hypothesis and an implantation strategy, and we will discuss the targets to implant. And from there, the neurosurgeon will program the robotic system. This is what the platform looks like, with an array of electrodes, each with a depth and an entry site, and therefore a trajectory. And this is where we can visualize vascular imaging, including an MRI with double contrast or a CT angiogram, and plan accordingly to protect the blood vessels there. In the bottom left, we see the robotic limb now comes into position and locks in place, and the surgeon works through the small port to make some holes with the drill, to pass a few set of tools to open the dura, and finally implant the electrodes. And the electrodes are held in place with bolts, as you see here in the bottom right. There are betadine strips wrapped around these for the antiseptic properties, but also for serving as a scaffold. As this material dries, it can actually help support the bolts even more, particularly in young patients, children, for example, or patients with very thin bone where the bolt might be a little bit mobile. This is an image showcasing some of the tools that we have to open the hole for the electrodes. So drills, small probes that can open the dura, the bolt itself that is implanted. We use a small tract maker to open the trajectory, and finally the electrode itself, which is secured. This is a video here highlighting the workflow in the operating room. So what you see here is, in this case, the robotic device. This is from several years ago, and we have preoperatively programmed it. It takes about 4 hours, 2 to 4 hours to make a careful plan. And in the operating room, we're able, therefore, to expedite the workflow by just driving from one trajectory to the next. The surgeon drills through the port, and you can see that happening now. So the scalp incision and the bone is drilled through. We use the robotic limb as a stop to the depth, and the bolt is placed. And now what you see is a very careful, we've already opened the dura, and now we're placing the tract maker. It's a small, delicate tool which serves as a stylet. And this is really the last stop where the surgeon can palpate for any blood vessels that might be in the way before committing to the placement of an electrode. And you will see that very soon. It's very delicate, and this is where the tactile sense, if I feel a blood vessel, for example, if you're not able to mobilize around it, then you abort the implantation at that location. And once that is safely made, however, we're now at the point where we will pass an electrode. There are various companies, all of them have their benefits and, of course, some disadvantages. And with these electrodes in place, we're able to pass them to a pre-measured depth and then lock the cap to hold them in position. We often will, conventionally, we will always perform some testing, about 20 minutes of recording in surgery to make sure that everything is working before we leave the operating room. So here we have, just get the laser pointer, the post-operative images. These are the photographs taken with the electrodes so that we can reference them during the study interpretation afterwards with the betadine strips. We take x-rays at surgery to look for, first of all, any deviation in the electrodes. An expanding hematoma will deflect them, for example. You see here that there's a very nice orthogonal strategy to this implantation. A few electrodes are actually crossing the midline, and we can do this in the orbital frontal region or in the anterior aspect of the cingulate gyrus, just underneath the falx. And that avoids, therefore, passing a whole new electrode from the other side. And once this is confirmed, the patient is taken for a CT scan shortly after surgery. And this is what this looks like, where we can see the location of the electrode contacts themselves. One can get quite fancy and generate these 3D images where we can see the implantation and where the electrodes pass in reference to the skull and the cranial cavity. But more importantly, below here, you see the Curie-generated software images which show the placement of these electrodes and where they pass through the different anatomical structures. And this facilitates our interpretation of the SEG. A brief word about the targets, entries, and trajectories. We adhere to the French School of Epileptology, and we use very similar nomenclature. Apostrophes denote the left side versus the right side, as in these two examples of different patients with either a frontal hypothesis or more of a perisylvian temporal hypothesis. And again, apostrophes denote the left side. On the right, the images are actually those from Dr. Tellerach's manuscript on SEG. And we attempt to achieve an orthogonal implantation as best as we can. This is an image that made it to the cover of Brain earlier this year in February, but it's taken from Dr. Tellerach's archives, showing how patients would pass the time in surgery. It shows a very nice depiction, though, of the grid array and the electrodes that are implanted in this patient. But typically, patients will spend 1 to 2 weeks on the ward now in the modern era, where we can record, we can perform testing and stimulation studies as well. And ultimately, the electrodes are then removed. And we do this very carefully to ensure that there is no broken piece left behind or broken electrode as well. Now, the utility of stereo EEG is not only in capturing, of course, the target region for treatment, number one here, identifying an epileptogenic zone, perhaps in a deep target somewhere in the orbital frontal cortex or in the mesial temporal lobe. But also, at the time of surgery, it can be very helpful for the surgeon. It can assist with surface localization. So what we mean by that is, if, for example, in this image on the right, you see the tattoo of the SEG electrodes in the cortical surface itself. You see our close proximity to blood vessels as well. And this can help the surgeon. And knowing, for example, that on this navigation study where we've recreated the SEG implantation for this patient, this is somebody who is undergoing a resection of the mesial frontal lobe. It was important to know that the anterior 2 electrodes were active in the ictal onset zone, but the posterior electrode was silent. And therefore, we knew that we had a posterior limit and, in fact, a boundary that helped guide the resection here on the posterior aspect. So surface localization is facilitated with SEG, as are the surgical boundaries. But also, additionally, I'll play this video one more time just to show that we were able to recreate these electrode implantations using depth electrodes and, in fact, capture intraoperative electrocorticography during surgery. And with a grid and some other electrodes applied, we were able to monitor these recordings and watch them go silent through and at the completion of the resection itself, which was very interesting and can be used to help guide surgery as well. Additionally, stereo EEG has opened up the capacity to perform radiofrequency ablation, which we now do here at the Cleveland Clinic as well. This is a patient who underwent this implantation, and the T' and U' electrodes are in the superior temporal gyrus, and U' captures the Heschel's gyrus, the anterior transverse temporal gyrus. And that's shown here in this red circle, where you could see that this upper bank of the sulcus was found to be a little bit abnormal. And so we took the patient to the operating room, applied a generator, and performed a small lesion along the length of that electrode at the hot spots, the contacts that were involved in capturing the seizure activity, the more lateral part. And this was done more of a diagnostic application towards identifying what would happen to the rest of the network. And we continued recording a few more days and took the electrodes out. And in this case, the patient was rendered seizure-free. It has been almost 7 months now, perhaps 8 months, and hasn't had any seizures. And so we're holding off with the resection for the time being until possibly the seizures recur. But it does highlight the fact that radiofrequency ablation can be facilitated and can now play a role in the diagnostic workup of SEG as well. Now, come back to a simple case where SEG played a role. This is a 36-year-old adult patient, right-handed, who had seizure onset at a very early age in childhood, at the age of 7. And at that time, the seizures were characterized by a dialeptic spell with behavioral arrest. It was occurring several times per day, and they were well managed on carbamazepine. And eventually the family stopped the medication after several years because the seizures had stopped, seemingly. By the age of 16, however, they recurred, and the patient was put back on medication and went through several trials of medication shown below. And by the mid-20s, the seizures had increased. And at this point, the patient was now on Keppra or levetiracetam, carbamazepine, and clobazam. There was a family history of seizures as well. And at the bottom, I just want to reference Dr. Bulasio, our neurophysiologist at the Cleveland Clinic, for this excellent case and for his great help with all of our SCG studies. Now, the seizure semiology in this patient was very interesting. It was characterized by a sound which sounded like waves or almost a sensation. And this was the aura, and noises in reference to this would become louder or softer, and then the room would begin to spin. And it always progressed from there. And therefore, the patient would have a decreased awareness, looking around with some abnormal tongue movements within the mouth, and the lips would often turn blue. And then the head could turn left or right, and often would conclude with an elevation of the right arm. Post-ictally, the patient was confused, and this was occurring frequently every 2 to 3 days. On EEG, for the sake of time, I won't go through the details, but suffice it to say that the ictal and interictal EEG patterns were consistent with right temporal activation. They all seem to localize to the right temporal region. An outside hospital, OSH stands for outside hospital, 3 Tesla MRI was reported as non-lesional. And when we looked back with our excellent neuroradiologist here, Dr. Ruggeri, he thought that perhaps the superior temporal gyrus had a little bit of blurring, very subtle, very difficult really to tell from the other side, but in retrospect looks a little bit questionable perhaps. We conducted what's called a VBM study, or a voxel-based morphometry assessment, and this was consistent again with this region in the right superior temporal gyrus. That looked a little bit interesting. And there was further corroboration from the ictal SPECT, showing here some activation in the right superior temporal gyrus, the right temporal lobe, as well as the orbital frontal region. And a PET scan showing on the coronal image here some decreased metabolism in the right temporal lobe and in the basal temporal region as well. A MEG study was non-contributory with multiple scattered dipoles on both hemispheres. And therefore, because there was not a great concordance of data, and with the subtle imaging that we saw, the very almost non-lesional MRI, the decision was made to proceed with stereo EEG. Amongst other things, you see here a perisylvian implantation, with the hypothesis being either the temporal pole or the temporal perisylvian region or the superior temporal gyrus itself, but also to assess whether to include the mesial structures or not in a possible resection. So you see here the electrodes themselves with the lettering that we have here, and this is the photograph. I have just a few representative slides to show the interictal and the ictal activity that was recorded. You see, firstly, with SCG signals that there is no muscle artifact. It's very clean. It's a little bit easier to interpret. And there was a fair amount of spiking activity along the superior temporal gyrus at these 2 electrodes, J and T, particularly in the lateral contact. So the larger numbers, you see it's quiet on the mesial side, but at J, the lateral ones showed some activation early on, and T as well. And this is, J electrode goes through the temporal pole and the superior temporal gyrus there at the planum polare and into the orbital frontal region. And T goes through the planum polare, that smooth part of the superior temporal gyrus in front of Heschel's gyrus. And Heschel's gyrus was activated a little bit later. And you see here a zoomed in view with some blue arrows showing that just a little bit more detail, J and T in comparison to the other electrodes. And this is summarized in this image here. So this was the interictal. Now, additionally, later on, the amygdala and the hippocampus were also showing some of this activity as well, and that's represented laterally by the dotted line. But here you see again a very careful circling of the 2 most involved regions in the lateral temporal neocortex along the superior temporal gyrus. Now, the ictal activity showed this even further, and classic seizures for this patient were collected with that wavy aura again at the beginning, And you see that J and T were the first electrodes to be involved more laterally again, with a later involvement at the U electrode site in Heschel's gyrus. So this tells us that it wasn't, in fact, the aura that was the first aspect. The aura followed the seizure onset at the J and T electrodes, in fact. And what you see later on in these recordings is that A and B, later on the amygdala and the hippocampus became involved as well, but much later. Just a zoomed in view showing how this looks when you come in closer. This is another example showing a very similar seizure onset. Again, this time showing J and T activation, and much later you see the amygdala and the hippocampus itself getting involved as well, more in these electrodes down here. Now, at the same time as recording seizures, we can also perform stimulation and assess and identify eloquent tissue. Now, SEG is not as good as grids at mapping eloquent regions, but it can identify some eloquent regions. And what we found in the stimulation part of the study, again, thanks to Dr. Bulasio, we found that activation of T4-5 at that contact site induced the classical typical seizure for this patient. And right away, you see that the J and T prime electrodes fire, and later on, the amygdala and the hippocampus come into a picture as well. So this was very good, strong concordance and good evidence that we were in the right area here. So this is the summary of the ictal activity. And based on that, a resection was proposed at our patient management conference, and the patient went on to have a resection of the temporal pole, including the superior temporal gyrus, effectively the lateral temporal neocortex, sparing the mesial structures, and you see that shown here in this resection. And it went on to become seizure-free and has been seizure-free now for nearly 3, going on 4 years, possibly by the end of this year. So the technology, therefore, for in vivo recordings from the human brain has improved dramatically. We can also couple this method with an improved understanding of structural connectivity. We can look at diffusion tensor imaging, for example, in the left, or we can perform through the stereo G electrodes what are called cortical-cortical evoked potentials, where if you stimulate one contact, you develop a structural map of what might be connected to that space. We have smaller electrodes. We can perform this with robotic guidance. Obviously, these are minimally invasive, and they're 3D implantations. And therefore, when the epileptogenic region can be found and disrupted, then surgery is very effective, either through resection or a disconnection or a laser ablation, for example. But significant challenges remain. One, finding the target remains difficult, particularly in non-lesional cases. How do we interpolate between the data, somewhere where we are not currently implanted, or how do we extrapolate beyond when we're wondering, is there activity beyond the site that we are recording from? And there are answers to this in mathematics and neuroengineering. And this is also going to refine how we stimulate for neuromodulation. We're in an era now where there are devices that can deliver stimulation, but we still don't know how to do this well. The where to stimulate, the what, with what, and how and when, the timing, the spatial and temporal aspect of it remains to be determined. We know that we need multi-site signals to study epilepsy. It's becoming clearer and clearer that this is a disorder of network dynamics, but we need to be able to develop further the ability to interpret SEG data and stimulate. We are now in an era of responsive neurostimulation, for example, through the NeuroPace device, which offers some ability to stimulate at the surface or in the depth, but this technology has a long way to go still. And I say that because VNS, RNS, and DBS all still have a very machine type of signal that is being delivered. This is the a square wave pulse. This is what the RNS delivers, is a biphasic pulse, in fact. But we need smarter ways to manipulate brain dynamics, looking at the dynamical connectivity, perhaps tweaking or modulating some mathematical or statistical property to disrupt synchronization and correct homeostatically the brain's dynamics back to a normal rhythm. And this will be, of course, tailored to each individual patient. This is what the future looks like. We have learned a lot about artificial intelligence and the emergence of applications for epilepsy surgery is astonishing, even at this early stage in the last few years. There are reports in the literature now on selecting patients or predicting outcomes or identifying epileptogenic targets, using AI to guide the SCG implantation. And I'll show a slide on that. And finally, what I was talking about, using the analytics now to guide neuromodulation and perhaps performing a personalized tailoring of epilepsy surgery. So a brief review of the literature over the most recent years shows how people are looking at high-frequency oscillations with machine learning, or interpolating the electrode sampling, what to do with a grid when you fail to capture part of the grid, for example. Can we assess what's going on there using the environment around it? And finally, reverse engineering high-frequency oscillations using deep learning methods. And ultimately, what we will find with time is as we collect this data better and better, as we are doing now, we will begin to look at the data and extract some features, pass them through some machine or deep learning algorithms, and develop a dynamical profile for the patient and decide surgical planning based on that. Here's a brief slide to show how robotics and AI have changed SCG planning. As we perform SCG, we need to take into account the fact that there are blood vessels in the way, there can be collisions between the electrodes, and so on. And this takes time, and the planning can take hours. We were very fortunate to publish on the emergence of robotics in neurosurgery over the years, and a lot has changed since this paper came out as well, but largely guided by the need to implant stereo EG electrodes and perform DBS in the epilepsy and functional arena, amongst other procedures. And this was a nice paper with many accuracies of these systems and the complication rates and so on. And here's a nice paper that highlights how AI has played a role. And these authors developed a multiple trajectory planning algorithm using artificial intelligence. And they modified all of their plans and trajectories and were able to generate excellent maps of up to 12 electrodes in less than 1 minute, all automated, versus the 2 to 3 hours of conventional manual planning. So there's a lot that technology can offer. But for now, suffice it to say that we need to work with colleagues in engineering and mathematics and computer science, physiology and genetics, and start to bring some of this big data, as we call it, together. And perhaps one day we will see what this diagram shows, that the collection of data, pre-processing, the study of EEG, extracting some feature or dynamical or statistical property that we can learn from using machine learning and deliver a stimulus to abort a seizure or perhaps at least forecast seizures more effectively. So in conclusion, epilepsy surgery continues to evolve. With these methods, we're able to record intracranial signals from the brain. We talked about grids, ECOG, and SEG. We have improved technologies now that are shaping how we deliver treatment based on these findings. There's been an evolution of neuroengineering and mathematical and computer science methods, now data science methods using artificial intelligence and machine learning, which will revolutionize how we study these signals. And finally, the last point is that we do require multidisciplinary collaboration to develop and advance this field, and bringing into the fold the ideas of AI, machine learning, robotics, closed-loop implantables, and so on. And I would just like to conclude with one nice quote by Dr. Penfield, who was sort of one of the first to capture this idea of dynamics and what's happening in the brain. And he said, "The brain is the organ of destiny. It holds within its humming mechanism secrets that will determine the future of the human race." Very optimistic quote. And that leaves us some food for thought. And thank you very much to the organizers again for inviting me. I'm very grateful to share in this time and learning so much from this meeting. And I'd love to take any questions. Thank you.
Thank you very much, Dr. Souletis. This was a wonderful presentation, and we have some questions accumulating in the chat, but we will leave them for the end of this particular session. And I pass the microphone to Dr. Sokhoudian to continue. Thank you.
Thank you. It's a great pleasure now to introduce Professor Case Brown, who will give a talk on the role of neuroimaging in epilepsy. Professor Brown is professor and head of child neurology in the University Medical Center, Utrecht. He leads the epilepsy research program, of the UMC Utrecht Brain Center. Professor Brown was trained as an adult and child neurologist in Utrecht, where he also obtained his PhD. He is a member of the steering committee and research council of the European Reference Center for Rare Epilepsies, EpiCare. His group initiated and coordinated several multi-center European research projects. You may be familiar with that. Time to Stop Study and Rescue ESAS trial, and developed individualized prediction models. These are online available calculation tools for those who can predict seizure recurrence after drug withdrawal, or to guess the possibility that diagnosis of epilepsy after the first seizure in children, or for cognitive outcome following pediatric epilepsy surgery. You can download these apps. Thank you. The floor is yours. We're very happy to hear you.
Thank you very much for this kind introduction. And to be part of this wonderful symposium. I would have loved to present in real time and in real life, but unfortunately I'll have to show you the video, so enjoy this, and I'm happy to take the questions afterwards. Good evening, good afternoon, ladies and gentlemen. Thank you very much for giving me the opportunity to discuss with you today the topic of neuroimaging and epilepsy. And I'll try to specify a little bit more, and will focus on actually structural neuroimaging in pediatric epilepsy surgery evaluation. Let's start with a case where we probably did wrong. A patient that was first considered to have an MRI negative or non-structural epilepsy. It was a 5-year-old girl, previously normal, with a normal family history and normal development. She developed episodes with febrile seizures, bilateral tonic-clonic seizures or atonic seizures, and cyanosis. At the age of 3 years, her interictal EEG showed more or less generalized spikes, Aboli spikes, and spike wave complexes, and bilateral synchronous frontal discharges. In the year following that, she developed axial myoclonias and frequent, also clustered, generalized tonic-clonic seizures with or even without fever. So the referring physician at that time diagnosed the patient with a probably genetic generalized epilepsy syndrome, possibly a myoclonic epilepsy syndrome. They had performed epilepsy gene panel investigations, SNP array, and metabolic evaluation all being normal, and they thought that given the diagnosis, an MRI was not requested. However, her seizures developed into refractory epilepsy, and she was referred for MRI under anesthesia with 3 Tesla, which was interpreted as being normal. You can see the actual T1, the 3D images here, as acquired at that stage. However, over time, her EEG developed into a more multifocal abnormality with interictal epileptiform discharges that were maximally located left frontally. So we decided to go back to the scan now with our dedicated neuroradiologist, epilepsy radiologist, looking at the frontal areas, and found an abnormality here, which is consistent with an FCD. And actually, this was confirmed on the 3D T1 images. So the patient was diagnosed with a focal cortical dysplasia. She was operated, the dysplasia was resected, she was seizure-free for a while, and then seizures recurred. And the reason for the seizure recurrence was actually something that we had completely missed, which is a large dysplastic area here in the left posterior quadrant. So what went wrong here? So first of all, the imaging recommendations or indications as put forward by the International League Against Epilepsy were not followed. And actually this is, although quite an old table, it still reflects the indications for imaging, which shows that in all pediatric epilepsies, neuroimaging is indicated, except in typical childhood absence, juvenile absence, or juvenile myoclonic epilepsy, or typical Rolandic epilepsy cases. The second thing that went wrong was that initially the MRI scan was not interpreted by a dedicated epilepsy neuroradiologist, whereas it was in the second time. And thirdly, we as preoccupied clinicians focused too much on the EEG clues and completely ignored the second lesion that was located more posteriorly in the hemisphere. So today I will discuss with you imaging in surgical decision-making, the impact of lesion detection. We will discuss what actually defines being MRI negative. I will show a little bit about dedicated protocols, the use of higher field imaging, particularly 7 Tesla, the use of post-processing imaging techniques, and the discussion in an MRI negative patient if he or she is lesional or actually non-lesional. So to start with the first, we do know already for a long time that patients with an MR visible lesion have a better surgical outcome. An odds ratio for seizure freedom is actually 2.5. And the same holds true for patients with focal cortical dysplasia, where seizure freedom is more frequently seen in abnormal MRI patients. And actually, the London group demonstrated 14 years ago already how important neuroimaging was in their pediatric multidisciplinary surgical team evaluations. They looked at a series of 353 patients, of whom 100 were considered ineligible for surgery and 238 were accepted for surgical treatment, curative surgical treatment. And of the patients who were offered a surgical procedure, the vast majority, as expected, had a unilateral MRI abnormalities. You can see here on the left, most of whom had a localized EEG, but also many having only a lateralized or even non-lateralized EEG. And actually, if the MRI lesion was localized, 92% of the children received resective surgery, and actually EEG telemetry in those patients did not modify decision-making. And obviously, if the MRI was normal or showed bilateral abnormalities, resective surgery was only offered if the EEG was localizing. There were, at that time, actually differences between continents, where you can see that this ILAE survey reflects the percentage of MRI negative patients and the differences between Europe, Australia on the one hand, on the other hand, the US centers. So no or only subtle MRI lesions were seen in 8% of the European centers and 19% of the US centers. And also a major difference was seen in the proportion of patients that underwent invasive monitoring, which was 40% in patients with an MRI lesion in the US compared to only 14% in MRI positive patients in Europe. And even in Europe, over time, we've seen differences in our pre-surgical evaluation protocols and surgical outcomes. When comparing the results and the indications of patients that were evaluated in the early 90s and those evaluated in 2010 or later, we found in 15 European centers that over time, we are operating more extratemporal lobe epilepsy patients, more malformation of cortical development. We use invasive monitoring more often, PET scans more often, and source imaging more often. And this all reflects an increased complexity of cases. However, the proportion of so-called non-lesional or MRI negative patients remains similar over time. But we should acknowledge that being MRI negative now certainly doesn't mean is not similar to being MRI negative then, considering the much better MRI techniques we have at the moment. So what actually defines MRI negative? So this is another example of a patient where we missed the pathology. This scan was first evaluated as being normal, but you can see in this 11-month-old child that there is an asymmetry in the volume and the myelination of particularly the white matter in the temporal lobe. It's clearly asymmetrical myelination and the extent of myelination and the volume of the white matter, which is consistent with focal cortical dysplasia or multifocal, multilobar hemispheric dysplasia. This patient was operated, became seizure-free. Another example of a patient whose MRI was considered normal at 4 months, but then we thought that there was an asymmetry in signal intensity that was first attributed to a B0 field inhomogeneity by our radiologist, but we suspected this actually to be reflective of an underlying dysplasia, and we performed a PET that very clearly showed hypometabolism in the posterior right-sided area, consistent or concordant with these T2 signal asymmetries. And this patient also was diagnosed with cortical dysplasia, was operated, and became seizure-free. We do know that over time, with aging, the visibility of lesions can change. For instance, this is a patient with tuberous sclerosis, where you can see that the tubers who were obviously already present early in life are much easier to detect on FLAIR images a few years later. And the other way around, patients with a focal cortical dysplasia can be very easily recognized at younger age compared to older age. You can see, for instance, that this dysplasia is better visible a few days after birth compared to 5 months after birth, with a decreased T2 signal of the cortex and the white matter. This was already published by the London group in 2005, where you can see the same phenomenon of a clearly visible cortical dysplasia that is more difficult to detect over time. Second, we need to realize that a dedicated epilepsy protocol and a dedicated epilepsy neuroradiologist to evaluate the scans is very important for the seizure focus detection rate with MRI. And in this NICE series, 123 epilepsy surgery candidates were evaluated with a proven histopathological lesion, and their scans were evaluated by non-expert radiologist and epilepsy expert radiologist, and standard MRIs were compared with dedicated epilepsy protocol MRIs. And actually you can see that the sensitivity for a focal lesion increased from 40 to over 90%. So what about these dedicated protocols? Already in 2009 and a few years later, this was the proposed ideal epilepsy protocol with a 3D T1 acquisition and a multi-slice coronal and axial T2 and FLAIR images. A few years later, we looked in the E-Epilepsy Consortium, which is the predecessor of EpiCare. There was a network of epilepsy surgery centers in Europe. We looked how often experienced epilepsy surgery centers actually use this proposed MRI epilepsy protocol. And of those 24 European centers, only 15 had access to a 3 Tesla MRI, and only 6, that's 25%, exactly followed the recommendations in terms of sequences, orientation, and resolution. Nowadays, this is the protocol that is advised by the International League Task Force. It's called Harness MRI, Harmonized Neuroimaging of Epilepsy Structural Sequences. It is to be used for children and adults on 1.5 Tesla and 3D scanners, and it consists of an isotropic 3D, T1 and FLAIR acquisition, and a very thin slice, no interslice gap, coronal T2 weighted 2-dimensional images perpendicular to the long axis of the hippocampus. You can see here nicely the quality of the 3D T1 and FLAIR images and the actual T2 multi-slice imaging that very clearly shows abnormalities in the hippocampus. We know that higher field MRI probably also has an added value, and within the same E-Epilepsy Consortium, we performed a systematic review and meta-analysis to look at the yield of higher field. And using pathology as a reference standard in this study, we collected data from cohorts that compared different field strength for MRI and looked at how consistent the lesion was detected compared to the presence of a lesion as proven with histopathology. And you can see that when comparing 3 Tesla versus 1.5 Tesla, the added value is 18%, and the same holds true, a little bit more, 23% for 7 Tesla compared to either 1, 1.5, or 3 Tesla MRI. So in general, higher field yields about 20% extra lesion detection rate. Interestingly, this added value of higher field was not seen for 3T over 1.5T in hippocampal sclerosis. Just to give you a few examples of how 7T can actually improve detection rate compared to 3T, this is an area that is possibly some blurring of the gray-white matter junction, and you can see that's on 3T, by the way. You can see here on 7T that there is a clear blurring of the gray-white matter junction, and that the normal cortical layering is absent in this area. The same holds true for these images, where a focal cortical dysplasia was not really detected, but 7T showed a very subtle transmental sign. And this patient, where you can see on the 3T images very blurry white matter signal intensities that are heterogeneous, but on the 7T images, a clear area in the depth of the sulcus with blurring of the gray white matter junction in the coronal and axial plane. Apart from higher field, some new MRI sequences could also help to improve lesion detection. For instance, in MRI negative patients with unilateral hippocampal sclerosis and temporal lobe epilepsy, diffusion imaging with an apparent diffusion coefficient, the symmetry index, can lateralize the epilepsy in a third of the patients. DTI also may have some value in the detection of a lesion in MRI negative focal epilepsies, but the localizing value is relatively limited, with 20 to 40%, and very similar percentages to the false localization rates of these kind of techniques. And this also holds true for other more quantitative MR analysis techniques like double inversion recovery or magnetization transfer ratios. And in general, these kind of new techniques may lead to detection of a lesion in classically MRI negative patients in about 5 to 16%, where the lesion is concordant with the proposed or hypothesized focus with video EEG. But also 5 to 42% of the patients will have abnormalities that are discordant with the proposed focus outside the lobe of the focus. So what about post-processing of MRI? There are several techniques to do so, like curvilinear reformatting, which is like peeling the onion, the skins of the onion, going from the outside to more the inside, where you can see that in the depth of the sulcus. In this way, the cortical dysplasia is better visible. Morphometry techniques, such as the surface-based morphometry techniques, a very good example is the MELT project led by Sophie Adler. You can also become a member or part of this project. It's a technique that uses machine learning and trained neural network classifiers to yield an automated lesion detection based on characteristics such as sulcal depth, curvature, blurring of the gray-white matter, and cortical thickness. This technique was validated a few years later in Cleveland, where 61 patients were investigated with a proven FCD type 2 based on histopathology. This kind of surface-based morphometry led to detection of a lesion with a predictive accuracy with a region under the curve of 0.75, sensitivity of 74%, specificity of 90%, and actually in half of the MRI negative patients, the lesion was detected. And false positive clusters were only seen in 3 of 120 controls and 8 of the 61 patients. The most well-known post-processing technique is the voxel-based morphometry technique, such as that proposed by Huppertz et al., that is looking mainly at the extension of the gray matter, the gray-white matter junction, based on 3D T1 images. So this technique was validated also in Cleveland in adults and children, looking at gray matter, white matter junction maps. For instance, in this series of 78 operated children that were initially considered MRI negative, this group was reevaluated by a multidisciplinary team meeting, where half of the patients were actually found to have a strictly non-lesional MRI, and the other half had a subtle lesion. And they also looked at 370 healthy children on 3 Tesla. So this morphometry program was used to detect possible lesions. And interestingly, if a lesion was detected and that lesion was fully resected, the seizure freedom rate, 72%, was much higher than the patient who underwent surgery where no morphometry abnormality was seen. And in general, 56% of the children had a positive lesion with this kind of morphometry technique. And in the MRI, the truly MRI negative patients with a MAP lesion that was fully resected, all of the patients became seizure-free. So finally, I'd like to discuss with you some more basic issues about differentiating MRI negative patients that are lesional from those that are non-lesional. Because we have to realize that MRI negative epilepsy is not the same as non-lesional epilepsy, and it's not the same as genetic epilepsy. Some of the patients with a lesion may not be visible on the MRI. Some abnormalities on the MRI that are visible are not related to the epilepsy, and genetic epilepsies can actually be related with an associated MRI abnormality, or they can be MRI negative. So in general, we would say that a genetic epilepsy is diagnosed when the epilepsy, the seizures, they result directly from a known or presumed mutation, and they are the core symptom of the disorder. But obviously, many of the metabolic and structural etiologies also have a genetic cause, and the other way around, in presumed genetic epilepsies, very often a single and specific genetic cause cannot be identified. So looking at the genes that can cause epilepsy and differentiating between structural, non-structural, and focal and generalized, this is the quadrant of genes that may be relevant because they can cause structural and focal epilepsies. So they may be considered in patients with who are candidates for epilepsy surgery. And some of these genes can actually be structural, but also non-structural to make things more complicated. So when looking at the relation between genetic underlying etiologies and seizure outcomes after epilepsy surgery, and pulling the literature results in 2018, we looked at three groups: patients with a mutation in a channelopathy gene or a synaptic transmission gene, mTOR or GATOR1 related gene mutations, and chromosomal abnormalities. We found that seizure outcome was better as expected in the MRI lesional group, but also much better in the mTOR pathway related genetic abnormalities compared to the channelopathies. And this is now becoming more and more clear. The GATOR1 related gene mutations are very often related to actually structural epilepsy. It's a very frequent genetic finding in MRI negative focal epilepsies. Very often these are frontal lobe epilepsies or variable foci epilepsies. But in a pooled cohort of 17 series, actually, almost a quarter of these patients had a malformation of cortical development. And if these patients were operated, their seizure outcome was quite good. This is a more difficult quadrant. The genes that are responsible for the so-called idiopathic focal epilepsies that are not associated with a structural lesion. And this is important because we are implanting more and more patients, MRI negative patients, where we suspect there is a lesion. We cannot see it. So we will perform invasive monitoring, stereo EEG, trying to find the focus. And unfortunately, over the last few years, we are implanting more patients, although the percentage of patients that eventually undergo resective surgery is also increasing. And 30 to 55% of those resected patients will actually not become seizure-free. So we're probably talking here about a group of patients who do not have a lesion. And we know that this group performs relatively poorly in terms of surgical outcome. So based on this European Epilepsy Brain Bank Consortium, we recently had the opportunity to have a look at 217 truly non-lesional patients. So these were patients who had a normal MRI, they underwent resective surgery, and the pathology was negative. And the outcome was rather poor. In this total group, at 5 years after surgery, only a third was seizure-free. And there were clear differences between the temporal and the extratemporal group. So 16% of the extratemporal patients became seizure-free 5 years after surgery. And many of those underwent invasive monitoring. From the 217 in total, 157 underwent invasive monitoring. And of the extratemporal patients in this group, 5 years after surgery, 16% were seizure-free and 84% were not seizure-free. So we're talking here about a group of patients with a normal MRI, undergoing invasive monitoring, undergoing resective surgery with a normal pathology and a poor outcome. So these are non-lesional patients, and we really would try to prevent unsuccessful monitoring and unsuccessful resective surgery. And possibly, these patients could represent a group of genetic, truly non-lesional epilepsies. And although this group has not been investigated as such, we can imagine that in this group, there are several patients with a truly genetic focal epilepsy with a poor outcome. We do not know what their eventual seizure outcome could be if there is a genetic focal epilepsy that is not related to the GATO1 pathway. Is the source confined enough to consider surgery? Is it consistent enough to consider surgery? And is it actually indicated to perform invasive monitoring and resective surgery? To differentiate between structural and genetic epilepsies, we probably need new genetic biomarkers, and probably we also need to perform routine genetic testing in MRI-negative patients to prevent unsuccessful surgery. And the idea here could be that if you have a patient that is MRI-negative, but a consistent focality and a very concordant EEG and semiology, and you perform genetic evaluation and you find a mutation in a channel gene or a synapse gene, that these are poor candidates, and we could consider stopping the pre-surgical evaluation. But if these patients would have a mutation in an mTOR or GATO1 related gene, that could be a justification to further explore the presence of a lesion using, for instance, high-field MRI, post-processing, SysCom, to proceed to invasive recording and possibly resection. So to conclude, we are operating more and more children over time, more and more malformations of cortical development, less temporal surgeries, so in general reflecting higher complexity. Being MRI lesional is an important predictor of surgical outcome. We need to improve our lesion detection rate by using dedicated protocols, asking our dedicated epilepsy neuroradiologists to evaluate the scan, and if necessary, repeat our imaging or go back to the first imaging procedures earlier in life, and sometimes the dysplasia may be more easy to detect. Increasing our field strength will add a little bit to the detection rate, as will our post-processing techniques. We need to realize that being MRI negative is not the same as being non-lesional, and the differentiation between structural and genetic cause of epilepsy is very difficult, but it's the basis of our pre-surgical decision-making. Thank you very much for your attention.
Thank you, Dr. Brown, for outstanding lecture. We have, I think, 10 minutes left for some questions. To address some of them, I think I'll start with the one which is for you, probably. This is about the duration of anti-seizure medication therapy after the surgery.
What is the exact question? So how long should we continue? Yeah. This question depends on the cohort and on the patient. In children, we know, we have investigated this, that early discontinuation in patients with a probably curative and successful surgery is safe, and timing of medication withdrawal does not relate to eventual seizure freedom or medication freedom in the end. So withdrawal after a few months will earlier unmask incomplete success of the surgical procedure, but it will not affect the outcome. So we tend to start withdrawing quite early, and we know that parents want to do so, and most parents are very happy to reduce medication because they see the improvement in cognitive function of their child. However, the consequences of a seizure relapse are very different in young children compared to adults, particularly if you have a driving license and a profession where, or living unsupervised, where a relapse after finally having become seizure-free since surgery can have major consequences, psychological consequences and other consequences. So the experience is that drug withdrawal is much less frequent in adults. And in the European study of 9,000 patients, we found that after 5 years, around 40 to 50% of children had no drugs anymore, compared to only about 20% of adults. So it really depends on the person, on the individualized risk prediction, on the consequences of a relapse. But for children, we know that the timing itself doesn't matter. So you can start early, but you have to counsel parents that you will know earlier on whether or not the procedure led to this anticipated success.
Thank you for this comprehensive answer. We have some more questions in the chat. Dr. Khachatryan.
Yeah, thank you very much. Few more questions. We have some time, and probably this one for Dr. Serletis. Adelina Karakhanian asks some more technical questions, probably. Is insertion of electrodes really safe? Maybe there is some damage to the tissue, and how long the electrodes may stay in the brain? Maybe you can answer these first two, and then we continue.
Yes, I'm happy to. She has a few questions. I can see them.
Yeah.
It's a great question. The electrodes themselves are very small. They're 1 millimeter in diameter. And remember, we are placing these guided by knowledge of the anatomy, the electrophysiology as well. They are safe if it's done safely, meaning we maximize our visualization of the blood vessels. We spend several hours to plan the placement of these stereo EEG electrodes. There is very minimal risk, but what I tell patients typically is, and this is based on our experience here, there's about a 20% chance of having some change, a small hemorrhage, a small contusion on imaging, non-symptomatic. There is a 3% chance of having a symptomatic bleed, for example, and there's a 1% chance, but transient and resolves, and there's a 1% chance of a permanent stroke. And this is something that even in comparing with my colleagues in Europe and other parts of North America seems to be a fairly standard risk experienced by all. And therefore, we don't just liberally resort to SEG, we maximize the workup. It does work, but there are some risks, and we go through it very carefully with the patients. In terms of what we can do with the electrodes, we talked about recording and stimulating. It's not yet approved for radiofrequency ablation in North America, but that is coming on the horizon. In Europe, they are further ahead in this regard, though. And so there's a lot to be gained with these electrodes. Now, she also asked what happens with the holes after we take the electrodes out. They fill with cartilage effectively over time. Young children can, of course, form a little bit of bone as well if it's in a younger aged patient. But typically they will heal up and fill with some cartilage. It's not typically a problem when we remove them, carefully making sure everything has come out. We put a stitch, most importantly, to make sure there's no CSF leaking out. They do stay on on antibiotics the entire time these patients are implanted, and the duration can range. Usually I defer to my very kind neurology colleagues who tell me we have enough data. The average ends up being about 10 days in hospital. There are centers who do it much shorter stay, perhaps 3 to 5 days, and then they take out the electrodes. We're fortunate at the Cleveland Clinic, we have the resources to keep them for longer periods. The longest patient I've had, for example, is 35 days, someone who didn't have seizures until the very end. But at that point, you start to worry about infection and so on. So I hope that answers some of the more technical questions there.
It is, of course. Thank you. I think we did all the questions Adelina was asking. Maybe the minimal distance between the electrodes?
We spaced them out. Yeah, it's a very good question again, and it highlights something important about stereo EEG. With the advent of robotic technology, it made the procedure overall a little bit easier. And what we've seen is that centers suddenly fell into this mindset where having a robot means you can do SEG. That is not the case. And that's why we even here at the clinic, for example, and other centers, we very much advocate for learning the exact process that Telerak and Bako followed to guide the placement of these electrodes. You can put them, you are guided by, again, the anatomy and the electrophysiology in terms of targets and entry sites and putting them in the brain. And some electrodes will be closer and some will be further spread out. It depends what network you are trying to sample. And so that's how I answer that question. If you're approaching the insula, you need a more dense implantation. Yeah.
Dr. Khachatryan, I think we still have 3 minutes to give a chance to Dr. Avitian to ask his question.
Well, thank you very much. I want to thank you again for the speaker's excellent talk. Just a question I have about what's the gold standard, Dr. Serletis? How can you measure the metrics of success at the hypothetical planning before the procedure? How can you tell we should have had a better planning or not?
The only way is to know if you achieve seizure freedom. And so that's a retrospective thing. SEG has made the difference, though. We have patients who have failed, for example, large craniotomies for subdural grid monitoring. And SEG opened up the door, the possibility to bring these patients back and implant in a very careful way. And we were able to localize surgically accessible targets like this. So it can be very, very safe and very effective at what it does when there's no other test that will do the same thing. But ultimately, we don't know until we follow the rules. We do the SEG, we do the resection, and we look back and say, do we have seizure freedom? And that it takes
the question about the planning rather than placing. So if you plan and place and you cannot detect the resectable origin, do you go back and replan?
We can do that. You're right. Sometimes during the same admission, thank you for clarifying that question there. If our neurologists feel that perhaps the hypothesis is beyond, or we have captured something and we need a few more electrodes, we can go back in the same admission and implant a few more, again, very carefully decided electrodes to supplement the data set that we have. And that can make a difference as well. Yeah.
Okay. Thank you very much. I think we have strictly in time, and we will not continue with the oral answers, but maybe the speakers could stay for more minutes and answer a few questions there in the chat which could be relevant to this session. Thank you very much, everyone. And I think there was a big call from the translator to have a short break for his rest. Thank you very much to everybody, and we will see you in some 15 minutes. Okay.
Thank you. Bye.
Bye.
After the 1988 earthquake, people from all over the world reached out to help Armenia. The disaster took away 25,000 lives, leaving hundreds of thousands homeless and destitute. In those days, aid relief from our compatriots living in the US, Archbishop Torgom Manukyan, Gevorg Hovnanyan, and Dr. Edgar Housepian reached Armenia. The aid would later be remembered as the first humanitarian aid to Armenia by the Fund for Armenian Relief. Since then, the Fund for Armenian Relief has implemented more than 300 humanitarian projects in Armenia and Artsakh. For 25 years, medical programs were headed by Edgar Housepian, clinical neurosurgery professor in Columbia University Medical School, vice president of the Fund for Armenian Relief. During those years, Dr. Housepian met and became friends with the First Minister of Health of our newly independent republic, Professor Ara Babloyan. Together, they initiated a number of innovations aimed at the development of healthcare in our country. Edgar Housepian would never raise his voice. He always spoke softly but clearly, confidently and imperatively. The imperativeness came from the fact that he justified the necessity and continuously followed that the necessity was brought into life and was implemented. It was very typical of Edgar. According to Edgar Housepian, the help to the motherland should not be only material. He wanted to see such a generation of doctors here that would not lag behind their international colleagues with their professional skills and knowledge, and what's more, would be able to educate others coming after them. For this very purpose, he organized the training of around 100 Armenian physicians in the United States and gave the idea of continuing professional development.
Edgar-ը շատ էր խոսում շարունակական բժշկական կրթության մասին
Edgar talked a lot about continuing medical education, which we can say remained with us as a legacy from him. And when I was in the National Assembly and headed the Healthcare Committee, we set out to establish continuing professional development in Armenia by force of law. And then, as a gratitude to the great professor, a new neurology and neurosurgery service was founded in Arapgir Medical Center and was named after Professor Edgar Housepian. In the field of pediatric neurology, and in particular epileptology, new opportunities were created for our leading specialists to develop other fields of neurology and neurosurgery, the main goal being the introduction of the epilepsy surgery in our country. It is because 30% of 3,600 patients registered in epilepsy follow-up care are drug resistant, and half of them need to undergo a surgery.
Մինչև 2014 թվականը մենք համագործակցում ենք տարբեր
Until 2014, we cooperated with US, Canada, and some European countries. But from 2014 to 2016, we sent 6 patients to the University Hospital St. Ivan Rilsky in Sofia, Bulgaria, where we underwent successful surgeries. Inspired by those results, we decided to have the same treatment method in our country as well. Since 2016, 32 patients have already been operated, most of them successful. In the beginning, those surgeries were performed once a year with the presence of Bulgarian colleagues, but now our neurosurgeon performs most of the operations by himself in Armenia.
Կարողանում է այդ վիրահատությունների մեծ մասը կատարել Հայաստանում։
The outcome of surgeries depend on proper pre-surgical examinations, which are possible to perform with high-standard equipment obtained thanks to our generous sponsors and partners. Starting from 2015, the team performs 24, 48, and 72-hour electroencephalographic video monitoring, which is an important test to diagnose epilepsy correctly. In 2021, for the first time in Armenia, specialists from Arapgir Medical Center performed the WADA test, the purpose of which is to determine the dominant brain hemisphere before the main epilepsy surgery in order not to damage the memory, speech, and motor areas of the brain. At the beginning of 2022, deep brain stimulation became a reality in Arapgir, which is used to treat movement disorders, including Parkinson's disease. It was performed for the first time in Armenia.
Զուգահեռ մենք ձեռք բերեցինք Edgar Housepian-ի
With the help of Edgar Housepian Foundation, we acquired a compound device called LexiFrame, through which we are going to introduce stereo EEG in near future, which is considered to be a high-level test in epilepsy surgery. Even today, with that device, we can perform surgeries on patients with movement disorders. By now, we have 2 successfully operated patients, a child and an adult, for whom this operation was the best solution because no drug could treat them. And just like this, step by step, the Neurology and Neurosurgery Service of Arapgir Medical Center is expanding, with the multidisciplinary team making efforts for patients' health and life quality.
«1988 թվականի երկրաշարժից հետո Հայաստանին օգնության ձեռք էին մեկնում ամբողջ աշխարհից։ Արհավիրքը շուրջ 25,000 մարդու կյանք էր խլել, 100 հազարավորներին թողել անտուն ու անապրուստ։ Այդ օրերին Հայաստան հասավ նաև Միացյալ Նահանգներում ապրող մեր հայրենակիցների Թորգոմ arczepiskopos Մանուկյանի, Գևորգ Հովնանյանի եւ դոկտոր Էդգար Հousepian-ի համատեղ ջանքերով ուղարկված օգնությունը, որ հետագայում հիշվելու էր որպես Հայ օգնության ֆոնդի ՀՕՖ-ի առաջին հումանիտար աջակցությունը Հայաստանին։ էին։ Այդ ժամանակվանից ի վեր Հայ օգնության ֆոնդը Հայաստանում եւ Արցախում իրականացրել է 300-ից ավել մարդասիրական ծրագրեր, եւ բժշկական ծրագրերը 25 տարի շարունակ ղեկավարել է Կոլումբիայի Երիցական բժշկական կենտրոնի կլինիկական նյարդաբանական վիրաբուժության ամբիոնի պրոֆեսոր Էդգար Հոսեփյանը, զուգահեռաբար լինելով նաեւ ՀՕՖ-ի փոխնախագահը։ Այդ տարիներին դոկտոր Հոսեփյանը ծանոթացել եւ ընկերացել է նորանկախ մեր պետության առողջապահության առաջին նախարար պրոֆեսոր Արա Բաբլոյանի հետ, նախաձեռնելով մի շարք նորարարություններ ուղղված առողջապահության զարգացմանը մեր երկրում։
Գիտեք, երբեք դուք չեք կարող որևէ մի անգամ նկատեք, որ Էդգար Հոսեփյանը ձայնը կարող է բարձրացնել։ Նա միշտ խոսում էր այսպես շատ հանդարտ ձայնով, հանդարտ ոճով, այսպես, բայց բավականի հստակ եւ բավականի այսպես իմպերատիվ։ Այսինքն այդ իմպերատիվությունը գալիս է, նորից եմ ասում, ոչ թե նա ինչ-որ ինտոնացիա էր ընտրում, ինչ-որ խիստ բառեր էր ասում, կամ ձայներ բարձրացնում, այլ գալիս էր նրանից, որ ինքը հիմնավորում էր անհրաժեշտությունը եւ շարունակական հետևում էր, որ այդ անհրաժեշտությունը ներմուծվի կյանք, որ դա իրականացվի եւ դա շատ բնորոշ էր Էդգարին։
Հայրենիքին օգնությունը Էդգար Հոսեփյանի համոզմամբ չպիտի լիներ միայն նյութական։ Նա ցանկանում էր այստեղ տեսնել բժիշկների այնպիսի սերունդ, որ մասնագիտական իր գիտելիքներով եւ հմտություններով հետ չէր մնա համաշխարհային առաջատարներից եւ ավելին կկարողանար կրթել նաեւ իրենից հետո եկողներին։ Հենց այդ նպատակով նա կազմակերպեց շուրջ 100 հայաստանցի բժիշկների վերապատրաստումը Միացյալ Նահանգներում եւ տվեց շարունակական մասնագիտական զարգացման միտքը։
Էդգարը շատ էր խոսում շարունակական բժշկական կրթության մասին, որը կարելի ասել, որ այսպես մնաց մեզ մոտ որպես ժառանգություն իրենից, եւ երբ որ ես արդեն ազգային ժողովում էի եւ ղեկավարում էի առողջապահության հանձնաժողովը, ապա ձեռնամուխ եղանք, որպեսզի եւ դա կոչվեց արդեն շարունակական մասնագիտական զարգացման այդ նախաձեռնությունը եւ այդ ծրագիրը եւ օրենքի ուժով մենք դա կարողացանք այսպես հաստատել Հայաստանում։
Եվ ահա որպես երախտիկ մեծանուն պրոֆեսորին Արաբկիր բժշկական համալիրում հիմնվում է նոր նյարդաբանության եւ նյարդավիրաբուժության ծառայություն, կրելով Էդգար Հոսեփյանի պատվավոր անունը։ Մանկական նյարդաբանության, մասնավորապես էպիլեպտոլոգիայի ոլորտում հանրապետության առաջատար մեր մասնագետների համար ստեղծվեցին նոր հնարավորություններ զարգացնելու նյարդաբանության եւ նյարդավիրաբուժության այլ ճյուղեր եւս, իհարկե որպես գերնպատակ ունենալով էպիլեպսիայի ժամանակ վիրահատական միջամտության ներդրումը մեր երկրում, որովհետեւ մանկական էպիլեպտոլոգիական դիսպանսերում գրանցված 3600 պացիենտների 30%-ի մոտ հիվանդությունը դեղորայքակայուն է եւ նրանց կեսը ենթակա է վիրահատության։
Մինչև 2014 թվականը մենք համագործակցում ենք տարբեր երկրների հետ, Ամերիկայի, Կանադայի, եվրոպական տարբեր երկրների հետ, բայց հենց 2014-ին մենք 14-ից մինչ 16 թվականները մենք թվով 6 պացիենտ ուղարկեցինք Բուլղարիա, Սոֆիա, համալսարանական Սուրբ Իվան Ռիլսկու հիվանդանոց եւ այնտեղ նրանք բարեհաջող վիրահատվեցին եւ ոգեշնչված այդ արդյունքներից մենք որոշեցինք այդ նույն բուժման մեթոդը ունենալ նաեւ մեր երկրում 2016-ից մինչ այսօր մենք արդեն ունենք թվով 32 վիրահատած հիվանդ բարեհաջող մեծ տոկոս բարեհաջող թվով եւ Սկզբում այդ վիրահատությունները կատարվում էին տարեկան 1 անգամ միայն բուլղարացի գործընկերների ներկայությամբ, իսկ վերջին տարիներին արդեն մեր նյարդավիրաբուժը ինքնուրույն կարողանում է այդ վիրահատությունների մեծ մասը կատարել Հայաստանում։
Արդյունավետ վիրահատությունների Հիմնական երաշխիքը որակյալ հետազոտություններն են, որոնք հնարավոր են դարձել լավագույն սարքավորումների միջոցով ձեռք բերված հավատարիմ գործընկերների օգնությամբ։ 2015 թվականից թիմը սկսեց իրականացնել 24, 48 եւ 72 ժամյա էլեկտրաենցեֆալոգրաֆիկ վիդեոմոնիտորինգ, կարևորագույն հետազոտություն էպիլեպսիայի ճշգրիտ ախտորոշման համար։ 2021 թվականին առաջին անգամ Հայաստանում արաբկիրցիները կատարեցին WADA թեստ, որի նպատակն է նախքան էպիլեպսիայի բուն վիրահատությունը որոշել դոմինանտ կիսագունդը վիրահատության ժամանակ խոսքի, հիշողության, շարժողական կենտրոնները չվնասելու համար։ 2022 թվականի սկզբին արաբկիրում իրականություն դարձավ գլխուղեղի խորանիստ ստիմուլյացիան շարժողական հիվանդությունների, այդ թվում պարկինսոնիզմի ժամանակ, կրկին առաջին անգամ Հայաստանում։
Զուգահեռ մենք ձեռք բերեցինք Edgar Housepian-ի ֆոնդի օգնությամբ մի բարդ սարք, որը կոչվում է Lexel Frame, որի միջոցով մենք պատրաստում ենք մոտ ապագայում նաև ներդնել ստերեո էգ, որը հանդիսանում է էպիլեպսիայի վիրաբուժության ամենաբարձր մակարդակի հետազոտություն։ Բայց արդեն նույնիսկ այսօր այդ ֆրեյմի օգնությամբ մենք կարողանում ենք վիրահատել շարժողական խնդիրներ ունեցող հիվանդներին, այսօր միայն 2 հիվանդ, երեխա եւ մեծահասակ, բայց շատ բարեհաջող։ Այդ կուզենայի շեշտել, որովհետեւ որևէ դեղորայքային բուժում այդ հիվանդներին չէր կարող առողջացնել, իսկ այդ վիրահատությունը պացիենտների համար կրկին փրկություն էր։
Այսպես քայլ-քայլ առաջ գնալով էլ ընդլայնվում է արաբկիր բժշկական համալիրի Էդգար Հուսեփյանի անվան նյարդաբանության եւ նյարդավիրաբուժության ծառայությունը, բազմամասնագիտական իր թիմով չխնայելով ջանքերը հանուն պացիենտների առողջության եւ կյանքի որակի։
Այստեղ գյուղում ժողովարին ասին ով ուզում է սենց բաներ անի, ես էլ գնացի մասնակցեցի ու հետո դասընթացներ արինք, շահեց այդ ծրագիրը ու դա սկսվեց։
Բավականին երկար ժամանակ ընտրություն է եղել աշխատանքային process-ի մեջ ու դրա համար ես վերապատրաստման կարիքս ունեի։ Շատ գոհ եմ եւ ինֆեկցիոն հիվանդանոցի բժիշկներից, ովքեր իմ վերապատրաստումով զբաղվում են եւ հովի մասնագետներից։
Օգտվում եմ բարեգործական ճաշարանից եւ հաճախել են իմ պապիկ տատիկը շատ վաղուց 90-ական թվերից լսել էր որ հովը բազմաթիվ ուսանողների աջակցում։ Մի քանի օր հետո զանգը ստացա, ասացին որ շնորհավորում եմ, կանցել է քոֆի մարտիկյան կրթավճարը։
8 տարեկան երեխա էս տղես։ Ասма հայը պարտվող չի, մենք չենք պարտվել, մենք մեկը հաղթելու ենք։ Դա ես իրավունք ունեմ հաղթել, պարտվել, պետք է առաջ գնանք։
Good evening to everyone. Welcome to the last session for today. My name is Ani Gevorkyan and I am a pediatric neurologist at Arabgir Medical Center in Yerevan, Armenia, and I will be serving as your moderator for this session. You will be hearing a presentation from Professor Bert Minasyan on this very timely subject, which is gene therapy making the child whole again. I would like to introduce Professor. He is the Division Chief of Child Neurology and serves on the faculty of the Children's Medical Center Research Institute at the University of Texas Southwestern Medical Center. Professor Minassian is a pediatric neurologist whose clinical specialties are epilepsy, neurodegenerative diseases, and neurogenetic conditions. One of his primary interests has been Lafora disease, for which his lab discovered the genes and gene therapy for neurological diseases of children. Welcome, Professor Minassian, and the floor is yours.
Hello, everybody. My name is Berj Minassian, speaking from the University of Texas Southwestern. What I tried to put on my first slide is a picture that summarizes most of child neurology. You'd be surprised, but let me explain. Basically, in child neurology, we have a patient on the one side, and then in the middle, we have the big black box of the brain. The brain is the most complex structure in the known universe, and one day we will figure it out, and we know a lot about it already, but it's still quite black and opaque, and we don't really know how it works. And that's the organ that we're trying to address in our patients. But on the other side, we know the causative defect in the gene for most of our patients, for the vast majority of our patients. So many of our patients have single gene defect disorders now. The mutation in the missing gene manifests in many ways. For example, if a gene product is needed to sustain the brain, if you lose that protein, then you have a neurodegenerative disease. Another example is if you need a particular protein in a very specific part of the brain, and if that protein is not there, you can have a focal abnormality, like a focal epilepsy that may require surgery. But the most common situation is if it has to do with developmental diseases. So for most of our patients, the gene is required during the development of the child. And as you know, the brain uses the vast majority of the genes in the genome. Therefore, it uses many thousands of genes. And unsurprisingly, there are several thousand different genetic causes of neurodevelopmental problems. In each case, basically what is happening is we are allowing the brain to develop while missing a critical protein. Now, imagine the future. The future is where we can replace this protein and allow the brain to develop normally. How far is this future? This future is not far at all. So imagine the new neurology, the new child neurology of the future. We're talking about all these phenotypes that we know, that we see in the clinic, where we are basically unable to help much, and we give sad news to families. We will have a whole new set of thousands of phenotypes of children where the problem has been solved at the root, allowing much better, if not normal, development. So even today, we are able to deliver the missing gene brain-wide in newborn animals. The animal studies, whether mice or larger animals such as monkeys, are clearly showing that if we treat an immature newborn brain, we can distribute the virally delivered gene product very widely across the brain. Now, if we do gene therapy in older children or in adults, we cannot. We're currently limited at about 20% distribution in the brain. So 20% of the cells will get the gene product. So there's a huge advantage in child neurology compared to adult neurology, for example, and especially in our diseases that start so early because they are developmental, that we could potentially fix the problem brain-wide early on in the newborn child. The issue we have is because there are these thousands of diseases, how do we know what disease is going to befall a particular child before it's too late? That requires newborn screening for thousands of diseases. How can we do that? Well, $100 genomes are almost here. Currently, a genome sequencing costs as little as $600. That's already affordable, but it's heading towards $100 soon. This means that any child who is born, we can do a whole genome sequencing and identify in case they have a missing gene that will cause grave damage to their development, and try to replace that gene as soon as possible and allow the brain to develop normally. What about adult neurology? How is the situation different? Indeed, there are adult neurological conditions that are single gene defect disorders. Huntington's disease is one, several forms of ALS, some forms of Parkinson's disease. But by and large, adult neurology, at least the genetic forms, which are very, very common, are caused by polygenic disorders where multiple genes have variants that contribute to the phenotype. Let's just take the most common, by far the most common example, and that's Alzheimer's disease. And this slide just shows susceptibility genes for Alzheimer's disease, and you see there are so many. So adult neurology is similar to child neurology in many, many cases. The only difference is that it is mostly polygenic and therefore more complex. But if we learn how to replace a missing gene in child neurology, maybe we can do the same in adult neurology. We just would have to break a bigger set. So in this slide, I try to show that. Let's say we needed 5 different gene variants to cause Alzheimer's disease. If we only have 3, you do not get Alzheimer's disease. So replacing the defective genes in two of the genes would be able to fix the problem. So what we will be learning in child neurology with gene therapy will be applicable to adult neurology, which affects all of us and everybody that is related to us. Even in adult neurology, we can think of treating with single gene interventions. Here is an example again from Alzheimer's disease, and although Alzheimer's disease, the causation is complex, but it is thought today that the major final common pathway is the formation of these misfolded tau proteins, which aggregate, accumulate like this, and lead to Alzheimer's disease. What if we could replace one of these tau proteins with one that no longer is able to receive the next tau protein, and thus prevent the aggregation and thus prevent the progression of Alzheimer's disease? So monogenic approaches to treatment of complex diseases. Since we spoke about neurodegenerative diseases, let's go back to pediatrics and look at the childhood neurodegenerative diseases. For some reason, in childhood, neurodegenerative diseases frequently present with epilepsy, and they are called progressive myoclonus epilepsies. This is an incomplete list. I filled as much of the page that I could. There are several others. I want to just say that most of these progressive myoclonus epilepsies are lysosomal diseases, and I highlighted those in yellow, and that has a particular significance, which we'll talk about as we go forward in the talk. So what is the vector that we use to replace a missing gene? It is a virus called adeno-associated virus. If you look at the top right of the picture, you see the great big adenovirus particles, and the arrowhead is pointing to an adeno-associated virus, the AAV virus that we use. This is a tiny little virus that was discovered as a contaminant of adenovirus preparations. This virus does not replicate, does not cause disease, and it has lived in humans as long as humans have existed. It is able to cross the blood-brain barrier. It is like the bacteria on your skin or in your guts. It lives with us and knows us, and we disregard it normally. what we do is we remove the gene contents of this virus, shown in the picture there in red and blue, and we replace that with the missing gene that we want to replace into the patient. It can accommodate most genes, but not all genes. It has a size limit, and there are certain genes that are too big for us to be able to do gene therapy. But for most genes, it can fit, and it will deliver the gene. The virus can be delivered IV because it's able to cross the blood-brain barrier, but the amount that it crosses the blood-brain barrier with is relatively small. And so IV approaches require a very large amount of virus, and then you end up treating all the other organs while your target is the brain, and sometimes it's not so good to treat all these other organs. So we prefer an approach directed to the brain itself. You can inject into the brain matter itself, or as we prefer, we inject in the CSF space, any place in the CSF, but lumbar puncture is one approach, and the virus will distribute to the brain. Here is an early experiment by Dr. Gray, my colleague who leads our preclinical gene therapy group here. And as you see, the virus will distribute broadly. This virus is producing a protein called GFAP, and you see, GFP, and you see how it's widely distributed in the brain of the mouse. But again, this extent of very wide, near complete distribution occurs in neonatal mice, and it is not nearly as good when you use older mice. So if you're dealing with a disease where the pathology is restricted to a very small area, here is an example. In this particular disease, it's the enzyme that contributes to making dopamine. These patients have this condition which results in them looking like baby Parkinson's patients, and the problem is in the subcortical parts of the brain. And so if you target the substantia nigra in this case, or the basal ganglia, the virus will distribute in the entire nucleus because it's such a small area. And already in 2012, we had great successes. As you see, this frozen child, and the virus is injected and the gene delivered, the motor phenotype dramatically improves, and the condition is essentially. So bottom line, with small foci to treat, it's easy, it's doable, it's all good. Even in older children, you don't need neonates. As I mentioned, in neonates, we get this type of widespread distribution across the brain, but for older children, we don't get distribution that is sufficiently widespread, and we get basically partial treatments. The example I showed you previously, because it's such a small area of the brain, we get complete distribution. What I'm showing you here is the special case of lysosomal disorders. Lysosomal disorders benefit from a phenomenon called cross-correction. Let me explain. So a lysosomal soluble enzyme, as it is being made, acquires the mannose 6-phosphate addition to the protein, and this mannose 6-phosphate modification is what mediates the transfer of the protein into the lysosome. Now, lysosomes, through the vesicular systems of the cell, fuse with the cell membrane, and the lysosomal enzymes can float freely in the interstitial space. Now, the cells have a way of recapturing these so that they're not wasted, and so there's a mannose 6-phosphate receptor at the cell surface. And so the protein swims in the interstitial fluid, and then is captured by other cells and internalized and transported back to lysosomes. So what happens in this situation is if you treat 20% of the brain cells, let's say in an older child with a lysosomal disorder, those cells become factories to distribute protein to the other cells. And gradually all the cells acquire enough protein, and the problem is really fundamentally corrected across the brain. So this is the phenomenon of cross-correction, which is a particularity of lysosomal proteins and lysosomal diseases. Some of you may know how we treat a form of lysosomal disease called CLN2 Batten's disease by injections of protein into the CSF space. Brineura is the name of the drug. The reason that protein works is because, again, by cross-correction, it distributes from cell to cell. The problem with that treatment, of course, is you have to inject the protein on a regular basis, whether it's once a month or whatever the frequency is. Whereas in gene therapy, you give the treatment one time, and then the cells themselves distribute to the other cells through the phenomenon of cross-correction. That's why I highlighted all these lysosomal neurodegenerative diseases in children, and all of these benefit from this cross-correction, and the results are looking very exciting for all these diseases with gene therapy. And I'll show you an example later. But I'm going to switch to Lafora disease, which is in orange here. And this is the disease that I've been working on for a very long time. We discovered the genes for this disease and are trying to understand it fully, but we haven't fully understood it yet. But we want to treat our patients in the meantime, as explained before. Before I go into that, let's go back to this question of the older children. Like I said before, we're looking into the future where we can easily do gene therapy on newborn children. But meanwhile, to prepare those drugs and be ready for this new future in child neurology, we need to do the experiments and treat older children. And as I said, in older children where the entire brain is affected, we have a ceiling of about 20%, and we can only treat about 20% of their cells. What can we do to improve that as we advance towards the future where we treat all these kids early on before they have so much damage? Here are just 4 things I listed. There are other things we can do. Number one is we can engineer proteins in such a way that that the protein, even if it is not a lysosomal protein, will behave like a lysosomal protein and will exit cells and enter neighboring cells and give the advantage of cross-correction. So we and others are working on methods to change proteins that are cytosolic, for example, to behave like lysosomal proteins and cross-correct. Another question is the immune system. You might ask, why don't we simply redose the patient? If the first dose gives us 20%, why don't we dose again and again till we get to 100%? The reason is because we give a very large amount of virus in gene therapy, 1 × 10⁻⁵, a quadrillion virus particles. And although the immune system doesn't mind this virus normally, when it sees such a huge amount of virus, it will react. No problem happens with the first injection, but if you try a second injection, you get 0 additional distribution because the immune system blocks it. So can we mediate the immune system to allow us to have multiple administrations, redosing? And indeed, there's lots of work going on in this area, and there's quite great advances that should lead us there soon. Third, can we evolve better AAV viruses that distribute more widely than the current virus that we have? And indeed, much work in this area going on, incidentally, including by groups related to the company Moderna that made the COVID-19 vaccine. That's just an aside, where viruses are being developed that distribute better, evade the immune system, etc. And finally, can we open the blood-brain barrier? As I said, the virus does pass the blood-brain barrier, but can we open the blood-brain barrier transiently and safely to allow much more access to the virus? And that, I'm just going to show you an example of that. So here we open the blood-brain barrier using focused ultrasound. So you see on the right side where the black arrow is, the hippocampus blood-brain barrier has been opened using focused ultrasound. On the left, the red arrow is intact. And we do the gene therapy during the brief period where the blood-brain barrier is open. And you see in the colored picture B in the middle, the large amount of brown indicating huge distribution of the virus and protein production, GFP, in the opened hippocampus, but not the unopened blood-brain barrier. So this is a simple approach that we are using to allow much wider distribution. Let's return to Lafora disease that I mentioned before, a non-lysosomal neurodegenerative condition. Just briefly, this disease starts around age 14, 15, and until that time, the child is perfectly healthy. As you see here in this young girl, looks perfect at age 14, and then she starts having myoclonic jerks, visual hallucinations, and a gradual dementing condition, as well as increasing intractability of her epilepsy. And finally, she becomes in a constant status myoclonicus state, eventually into vegetative state. The whole condition lasts 10 years or more, and it's a horrible condition. The myoclonus becomes completely constant, and there's nothing we can do to help these kids. It's an autosomal recessive disease. Meanwhile, the family may have had other children who see what's going on and know that they're at risk for the same. This is Chelsea when she was 21, and here just a brief video to show you what they were like over time, and then she died sometime after the state. In the brains of these children are these massive Lafora bodies that you see in these various pictures. And these Lafora bodies consist of an abnormal form of glycogen. On the left side, you have normal glycogen. On the right side, you have the glycogen that is in Lafora disease. And the difference, as you see, is that the chains of glucans are longer in the Lafora glycogen, and this makes them precipitate, accumulate into Lafora bodies that drive the disease. Glycogen is synthesized by the enzymes listed on the left side, and Lafora and malin are two new enzymes. They're the causative defects of Lafora disease. And again, part of the black box, we know a lot about them at this point, but we don't know everything about them, and we don't exactly understand how they are important in preventing the normal glycogen that you see on the left become like the Lafora glycogen on the right. Meanwhile, our patients are dying and we want to help them. And as I said, we can do that with gene therapy, and we are doing gene therapy in Lafora disease, but we can also intervene at other places, like at the RNA and the protein. And our target does not need to be the causative gene. So in this case, I'm going to give you an example of where we're targeting a different gene than the causative one, namely glycogen synthase. Glycogen synthase in green here is the enzyme that elongates the glucan chains. So whatever the mechanism of formation of these abnormal glycogen in Lafora disease, in the end, it's glycogen synthase and only glycogen synthase that can add glucoses together and make these long chains. So what if we down-regulate glycogen synthase? Can we help Lafora disease? And that's what we did here. We used antisense oligonucleotide against the RNA of glycogen synthase, and we injected that in mice to down-regulate glycogen synthase and see what happens. And indeed, the abnormal glycogen accumulation normalizes, as you see here. The Lafora bodies improve dramatically, as you see in the top right graph. And if you look at the color pictures, you see in the bottom right corner is the animals treated with the antisense oligo against glycogen synthase, and the Lafora bodies cannot form when your glycogen synthase is slowed down. And the inflammation in the brain shown with the brown GFAP signal here goes away when you treat these mice with the antisense oligo against the glycogen synthase. So you get rid of the, you reduce glycogen synthase, you get rid of Lafora bodies, you get rid of inflammation and neurodegeneration in the brain. This treatment is waiting to start clinical trial soon. On the top left is Lafora himself. In the rest of the pictures are patients with Lafora disease, most of whom are deceased now, but there are many that come all the time, and we're hopeful that we can start our clinical trial soon with our antisense oligonucleotide to treat these patients. And imagine if we could treat them early on, you know, when they're born and prevent the whole thing, if we only knew early on that they had the diagnosis, if we could only do newborn screening on them, which we now can with the decreasing costs of genome sequencing. I will now show you an example in dogs of Krabbe disease. This is, unlike Lafora, which is not a lysosomal disorder, Krabbe is a lysosomal disorder. And these Krabbe dogs are treated with gene therapy, gene replacement for the missing enzyme. And I want you to see what happens to these puppies with Lafora disease. With Krabbe disease. This dog has Krabbe disease and is quite sick, as you see. And then the team here, Dr. Bradbury, Charles White, and Steve Gray, they give the gene therapy, replace the missing gene, and this is what these dogs will look like after gene therapy. So dramatic improvement because of the phenomenon of cross-correction. Now, here's an example of CLN7. This is another lysosomal disease. This CLN7, the protein product, is not a soluble lysosomal enzyme, so it will not benefit from cross-correction. It's a membrane-bound protein. This little boy's name is Jojo. He was diagnosed with this. His family moved to Dallas from Arizona so that they can support our gene therapy efforts. They raised several $1 million for us to have a program in gene therapy for this rare disease. They knew all the while that by the time we get everything organized and start in patients, by the time we finish all the preclinical work and get to the clinic, the boy may be too advanced. And indeed, he was too advanced by that time. He died around the same time that we actually started the clinical trial. He and his family raised the funds, but he did not benefit from it. But the other children who were diagnosed later, were younger, did benefit. I'm showing very preliminary video here. This is a small study of 4 patients, and this kid from Paraguay came and benefited from the gene therapy that Jojo and his family fundraised for, and she had the CLN7 gene replaced. This is extremely preliminary, but we already see improvements. Even though the protein product in question is not a soluble lysosomal enzyme and does not benefit from cross-correction. Slide again with all the kids we're losing all the time, and all the kids that are suffering all the time. But now we can diagnose them early and hopefully make them whole again and create the new pediatric neurology of the near future. Thank you for your attention.
Thank you so much, Professor Minasian, for addressing this interesting topic. This was really fantastic. I would like to apologize on behalf of Dr. Petya Dimova, as she was not able to participate in this session because of compelling reasons. And now, if you don't mind, we come to a Q&A part. Let's see what questions we have. So we have a question from Adelina Karafanian. The question is the following. Will introduced gene become part of DNA with AAV gene therapy?
Thank you, Ani, and everybody for this great conference. I've been trying to attend as much of it as I can. I'm actually in California for a wedding, and it's very early here. I attended what I could. But regarding the question, the plasmid from AAV9 is not inserted into the DNA of the patient. It sits as a separate plasmid on its own and just produces its own gene. So there is no integration in the human genome, which is a good thing, because in other cases where there is integration, who knows where the sequence will integrate, and it can cause other problems such as cancer and so on. So this is one of the advantages of this particular viral gene delivery.
Mm-hmm. Thank you so much. And the other question from Adelina Karafanian is the following. May AAV work like retroviruses, be in infected cell and infect the other cells, increasing therapy efficiency?
No, this virus, like was mentioned in the talk, does not replicate. So it stays, the virus envelope disintegrates, the plasmid stays in the particular cell, and there is no further spread. On the surface, it would seem that it would be an advantage to have replication and spread. This way the virus can spread the gene to all the cells, but that for now with current technologies would be too dangerous to allow a virus to, spread in the brain and cause all the problems that would do. It is for this reason that we have to put a very large dose of the virus, hoping that at least one virus gets into at least one brain cell, because there is no replication of the virus.
Okay, thank you so much. And I think there are no any other relative question, and maybe one question from my side. What do you think? How the small countries can contribute to the large researches taking part in the large cities?
This is a great question. These diseases we're talking about are ultra rare diseases. So just the examples that I showed, for example, CLN7, in that case, our study had 4 patients, 3 of them from other countries. One came from Romania, one from Paraguay, one from, I don't remember, and one from the United States. So in that regard, most of these studies usually are open to any country. The other thing that I'd like to say is this obviously, like anything else, is not easy, is not trivial, is very complicated, but honestly, it's not exceedingly complicated, meaning that with proper dedication, it can be established in smaller countries. I have mused several times myself about possibility of establishing gene therapy in Armenia. I really do think that it's possible, but it will require some good investment and backup initially. Maybe we can talk about that separately. I even went to some of the wealthy Armenians I know in Dallas and asked for support, but so far did not get it. I don't see why a smaller country cannot do this type of work. It's not more complicated than epilepsy surgery, and you're already doing that. Yeah, I guess that's what I can say for now.
Great, thanks a lot. And just to say that there are a lot of words of appreciation and admiration in the Q&A section. So probably I will pass the microphone to Professor Babloyan for closing remarks. Thank you.
Ճիշտ ասած, պրոֆեսոր Խաչատրյանը պետք է ամփոփի այսօր, ես վաղ եմ ամփոփում։
Okay, I'm sorry.
Okay, so as far as we have reached the end of this wonderful day of interesting information coming from the leading specialists in their fields. This was really a great session, a very stimulating one. And we are closing only the first day of this very interesting symposium. So there will be another one. We had wonderful sessions, including talks on seizure semiology, neuroimaging of epilepsy, some invasive monitoring techniques, and gene therapy, quite a wide variety of different topics, and very good friends of us coming to help us to make this happen. So a few technical stuff I'm asked to report. We had many questions regarding when and how the participants will be able to receive the certificates. Usually the events have around 1,000 participants, more or less. So the process will take around 40 to 60 days approximately. Please follow your emails and you'll receive notifications to the email addresses you provided for this event's registration. So for tomorrow, we have many interesting talks again about epilepsy surgery in children, video EEG monitoring, state-of-the-art neuromonitoring in epilepsy surgery, and a lot of more. So we encourage all the participants to join us tomorrow at 4 o'clock Armenian time, and another 4.5 hours of stimulating discussions with leading experts in their fields. Thank you very much, and till tomorrow.
Stay tuned.
Stay tuned.